Welcome to all. Good morning and welcome to our third international conference. It's the first time face to face. This time, the title of this conference, we choose two subjects, the diabetic acidemia and homocystinuria, because we think that these two diseases are both related to each other. Professor Johannes from Austria, Professor Mohammed Rain from Saudi Arabia, and Professor Fatih from France. I choose to talk today that what have evolved in the internet through the last 20 years from the control of these two diseases now, then, and before. Just to present how the disease was difficult in diagnosis and how we achieve the current diagnostic procedures and the treatment options. I will tell the story of 3 patients. Each has a different disease and some difficulties in diagnosis. The first patient is surgery to my work. We presented in 2003 at the age of 6 months. He was presented in the first open, not in the second stage. He had an older sister who died at the age of 1 month after an attack of gastroenteritis, severe dehydration, and loss of consciousness without proper diagnosis. The patient presented in another university with vomiting, anemia, and resistant metabolic acidosis. The pH was below 6.9, and the record was only 3, and the creatinine was raised up to 1.9. We suspected that the patient has organic acidemia. These are the follow-up blood classes in Alexandria University. Actually, the team didn't know what it was the diagnosis, but they offered the patient the routine treatment and supportive care, other fluids and bicarb, and as you see, the pH increased from 7.2 to 7.43, and the bicarb increased from 3.8 to 14.8, and the acid decreased to -10. At that time, we didn't have diagnostic already or gas control in Egypt. So we sent the sample to France, and the organic acid in urine received massive excretion of methyl acid, as well as dehydroxypropanate and methyl citrate, confirming the diagnosis of methyl acidemia. The patient started to receive ectoprotein and intravascular hydroxypropanate and protein restriction together with oral methyl maintenance solution. There was no available MMA formula, there was no available amino acid-free formula at that time. Looking for precise diagnosis, we needed further biochemical investigation and molecular testing, and I found this email that I sent back to 2005 to Professor René in France and Professor Olivier, looking if they can offer the patient molecular and biochemical investigation. And we took a sample, skin biopsy sample, and did the culture of fibroblast, and then we sent it to France, and they studied the enzyme activity of the fibroblast protease, and it appeared that it is so low in the fibroblast. As you see, it is less than 5%. And to know if this patient is responsible for vitamin B12 or not, because we were giving vitamin B12 3 times per week, first every day and then 3 times per week. They studied the protein incorporation of fibroblast cell culture with increased with with gradual increasing of hydroxyproline. And as the treatment content doesn't work, you will see that the propionate didn't increase concentration in spite of increasing doses of hydroxyproline, started from 0 to 1. And this indicates that the patient is not responsive to vitamin B12. And this was the follow-up of the hyaluronic acid that we used to send to USA, starting from 1,600 through the years, and we have never reached the optimal level. Our target, together with the range group, was to decrease the MMP level below 800. And when the patient started to go to school, the levels increased more, and we were not able to control the patient with hyaluronic acid. And in spite of this, the patient has average mortality, average weight at the height, although he is high level of the hyaluronic acid. And so, together with the parents, we were looking for better treatment in other countries. And I found the two levels in this file, contacting Professor Charles Delpini, the one responsible now for gene therapy for the hyaluronic acidemia. We include the patient for clinical trial, and also Professor Hélène in France, they can do liver transplantation for liver and kidney transplantation. And the parents should do that. It's better to do liver and kidney transplantation more than to put the patient in clinical trial. And while Professor Hélène advised that we should send the patient to Professor Zokol and Grossen if he can start with kidney and then liver transplantation, and then we prepare to do the kidney transplantation here in Asia. And while we were preparing the patient for kidney transplantation, unfortunately, the patient died during one attack of decompensation. Suddenly, that took less than 2 hours, and he was not able to reach a proper hospital for treatment.
We're honored to have Professor Johannes from Austria, and he will tell us about the inherited disorder of intermediary metabolism, and Professor Ola Khalifa, where she will tell you the current status of methylmalonic acidemia here in the genetic department, and how we evolved in diagnosis and management. Also, Professor Muhammad Al-Awain, he will present a talk about how to approach a patient with elevated methylmalonic acid. Another story with a different disease, but later, 6 years later, a 4-month-old boy, the first in birth order of non-consanguineous parish, presented with recurrent chest infection and recurrent blood transfusion due to severe macrocytic anemia. The hemoglobin was 4 g%, and in his record, they said that there could be metabolic acidosis associated. Because the patient presented with anemia, he was referred to the hematology clinic. And there they did bone marrow aspiration, and it revealed hypercellular bone marrow with immature cells. The patient was diagnosed to have vitamin B12 or folic acid deficiency, and he received both vitamin B12 and folic acid therapy, but there was no adequate response. After 2 years, the patient was referred to another genetic department or another genetic unit due to the presence of severe developmental delay. They assumed that the patient also diagnosed as methylmalonic acidemia. And so he started protein restriction with L-carnitine and continued on vitamin B12 and folic acid, but there was also no improvement, and the patient didn't regain any developmental milestones, whether motor or mental. The parents themselves were looking for better treatment. So he self-referred to us at the age of 2.5 years with severe failure to thrive, signs of protein deficiency, severe hypotonia, and some dystonic movement. When we did the initial investigation, there was no acidosis, no hyperammonemia, and at that time we had our tandem mass spectrometry, and the EMS didn't show any increase in C3. So we thought that we should send out the samples abroad, and we did quantitative plasma amino acid and revealed that there was low, it was normal, except there was low methionine level of 14 nanomole per liter, and the homocysteine level was 100. Plasma methyl malonic acid was normal, while organic acid in the urine revealed mild elevation of ethyl malonic and methyl glutonic acid of unknown significance. And because of the previous diagnosis of methyl malonic acids together with homocysteine, increase in homocysteine level, we sent the sample for cobalamin C and D deficiency, but it showed no mutation. So we had to re-evaluate the diagnosis, and we gradually introduced the protein together giving betaine therapy for homocysteine. The patient started to show improvement in weight, height, attention span, and motor development. He was able to stand supported for the first time at the age of 2 years and 9 months, and walk supported at the age of 3 years. The homocysteine decreased gradually, 69 to 69 to 66 to 69, as well as the MCV and hemoglobin increased. Organic acid was repeated, and it was normal this time, and the plasma amino acid showed the increase in methionine level increasing up to 34 micromole per liter. So because of the diagnosis was different now, we targeted the remethylation defect, and we did sequencing if methionine synthetase gene, and it revealed a compound heterozygous mutation of cobalamin G deficiency. The patient disappeared for several years, and at the age of 9 years, there was increase in dystonia, and we did MRI for him, and it showed the vasculopathic foci within the deep cerebral white matter bilaterally, more in the left side, with minimal selective atrophy regarding cerebellar nerves. There was no involvement of basal ganglia. There is no for the dystonic movement, but there was vasculopathy, meaning that the homocysteine was not controlled through these past years. We tried also, because the patient going to special school and also is not well compliant, although his weight and height are average, but he has moderate intellectual disability and mild dystonia of both lower limbs. The CBC is normal, and the methionine is 22, and the homocysteine is 90. But the MRI, MRA, and the MRV is still showing the signs of chronic homocystinuria. The MRV showed chronic retracted thrombosis of both sagittal and dural sinuses, and the MRI still showing the left frontoparietal white matter foci suggesting subacute ischemic lacunae, and the MRA showing subtle distal microangiopathy of cerebral arteries. So it is not only the mental retardation, but there is thrombosis, even it is not clinically apparent. Dr. Tawfiq Ibn Amran will talk us about the classical homocystinuria, current status, and the future direction. What about the current situation? How the patients present these days? This is story for the direct to consumer genetic testing. The patient doesn't go through all these investigations. This patient was referred from a society for autism. She was a 7-year-old girl, referred just to interpret the whole exome sequencing result. They did whole exome sequencing, but they don't know how to interpret the result. The result, it showed homozygous mutation of the MBDR1 gene for the cobalamin F mutation. She's the second in birth order, one of twin. Her twin sister is normal as well as her older 15-year-old brother. Her birth weight was low, 1.75 kilogram. She had global developmental delay with significant regression at the age of 1 year and was associated with autistic feature. And so the patient all through these 6 years, she was treated as autism. On examination, she had average weight, height, and skull circumference. 2 years ago, she started to develop skin changes, and it was diagnosed as eczema or infection. This is how these infections look at the ear and the darkness of her hands. This video will show how her skin changes in hands and feet. Some darkness of the skin and white and the pigmentation. So we did the basic investigation after the patient was diagnosed. The CBC showed anemia, the MCV was high, 99.6, and the white blood cells and platelets were both normal. Methylmalonic acid level is high, 0.2, and the normal is 0 to 0.4, and the methionine level was low, 11.1. And this is her follow-up all through the last list. Her hemoglobin increased from 9 to 11.2, and the MCV decreased to 97. Actually, it decreased after only 2 months of treatment. The methylmalonic level also decreased immediately after 2 months only of treatment. Methionine level increased, but it took some time to reach 25.8, and homocysteine decreased also after only 2 months of treatment. And there was also improvement in cognitive function, and the skin changes disappeared completely, and the patient has no recurrent infection, skin infection anymore. What about the future? What about them? I put that these consultants, Dr. Shayma, Dr. Nada, Dr. Radwa, Dr. Muhammad, and Dr. Abdullah, will form our future. This our 5 consultants throughout the last 20 years. We were only a unit, we were not a department, so we have only 5 consultants in the last 20 years. And in the past 20 years, we have 6 residents. And they will reshape the future of the genetic department. Thank you.
Thank you, Professor Soleh, for this informative talk. Appreciating all the details.
I'm very pleased to present Dr. Johannes Skok. He's a professor and chair of human genetics at the Medical University of Innsbruck, Austria, where he is also the director of the Department of Genetics. He is the head of the Center for Medical Genetics, Innsbruck. As such, he is responsible for the provision of the whole range of genetic services for Western Austria and beyond. His own clinical and research focus is on inherited metabolic and connective tissue disease. He is going to present an interesting talk about inherited disorder of intermediary metabolism, a group-based approach. Please, Dr. Johannes.
Yeah, now it's clear.
Thank you very much. So I hope all the technical problems can be solved, and you can hear me and you can see my slides. I'm very sorry that I can't be in Cairo myself. Personally, I would have loved to come. I've never been to Egypt. Would love to go and would love to meet you in person. Unfortunately, this is the first week of the semester and I am very busy with lectures and couldn't leave Innsbruck. So my task is to talk about a group-based approach to inherited metabolic diseases with a focus on the disorders of intermediary metabolism. Just to confirm, should I still use the allocated 40 minutes or should I cut it short?
Yes, at the same time, please. The same time.
Okay, thank you. So metabolic diseases are always regarded as a bit complicated and maybe difficult to understand. I would like to talk to you that this is really not the case, and when you really have a system-based approach to inherited metabolic disease, it's actually quite simple and you can easily diagnose patients. So what are inherited metabolic diseases? There are primary disorders, monogenic disorders of the biosynthesis or degradation of particular substance within metabolic pathways. So that's all quite relevant because it doesn't include structural proteins, membrane, channel proteins unless they have a function in a pathway. It doesn't include signal transduction, endocrinopathies, and so on. It's about pathway mechanisms in biochemistry, and in consequence, the pathomechanisms are really quite simple. Accumulation of toxic substrates or undegraded substrates, deficiency of a reaction product, accumulation of the reaction product, or disruption of the energy supply. They are important because they are often treatable. They are maybe a little bit difficult because they are multisystem disorders, but they have a dynamic disease course with acute decompensations, which I'd like to talk about today. But because we can do something, it is important to recognize them early. Just to highlight one way of maybe sorting out these 1,500 genetic monogenic diseases, we have developed a classification, ICIMD, which lists all the currently known metabolic diseases in a structure which allows you kind of a group-based approach where you think, which area does it belong to? Intermediary metabolism, lipid metabolism, and so on. And then you go into detail. Today, I would like to talk to you about intermediary metabolism of nutrients, because these are the disorders that are also have this metabolic crisis and require urgent intervention. The one source of information that you may actually find available is this book, Metabolism, which you may be able to get at the conference in Cairo. I don't know because it's supported by the sponsor. And what I'm talking about is also available in this book for you to read at home or on the emergency ward. So metabolic specialists sometimes like to present pictures like this because they want to show how clever they are and how complicated everything is. I'd really like to focus on this very simple summary of what I believe is relevant to treat patients with disorders of intermediary metabolism. So we have three major classes of nutrients: carbohydrates, proteins, and lipids. The most important carbohydrate is glucose, which is degraded to pyruvate in the cytosol, then transferred into the mitochondria and oxidized to chemical energy in the Krebs cycle and respiratory chain. Two other carbohydrates that are relevant are galactose and fructose that are fed into this pathway, and pyruvate and lactate are about the same, only a little bit of difference because of the oxidation state. But that's carbohydrates. That's all you need to really know for the start for this group of nutrients. Proteins are chains of amino acids. Amino acids are called amino acids because they have an amino group. The degradation involves various steps, more shorter or longer pathway. At some stage in the cytosol, ammonia is cleaved off and then fed into the urea cycle to be excreted as urea. And then the amino acids turn into organic acids. They are introduced into the Krebs cycle and metabolized to chemical energy. Finally, lipids are stored as triglycerides in the fat tissue to provide energy when you need it, and that is after, say, 8 to 12 hours of fasting. They are released. The triglycerides are activated by coenzyme A, transported via the carnitine shuttle in the mitochondria, and metabolized via beta oxidation to ketones. Also some to chemical energy, but the ketones that are produced by fatty acid oxidation then serve as alternative sources of chemical energy for the muscle and the brain. So lipids to ketones is an important pathway for the provision of energy during fasting periods. So in every hospital, I trust also in Egypt, there are some basic metabolic tests that should be available for every sick patient, every acutely ill child in the admission unit. This is blood sugar, the acid-base status, which you can do with a simple machine, and a keto sticks, usually in urine. And then there are two maybe less frequently used but quite important analysis, that's lactate and ammonia. So these 5 tests are really the basis for diagnosing patients with acute metabolic crisis. And when you think there is something that goes into this direction, that there is a number of special metabolic tests that should be available on an emergency basis. I'm not familiar with the situation in Cairo, but I trust that you can get this also rapidly. Usually this should be available even within half a day, on weekends or on bank holidays and so on. That includes amino acids, organic acids, and acyl carnitines. That's also used for newborn screening. And free fatty acids or maybe just triglycerides are helpful also to assess lipid metabolism. So this is a portfolio of metabolic tests that should be available, that I trust will also be or are available. And when you actually use these wisely, you can make a lot of diagnosis in the emergency situation, and can start the appropriate treatment immediately when necessary. So a very simplified way of looking at metabolic diseases is also looking at the manifestation types. Some manifest with an acute crisis, intoxication or hypoglycemia, and I would like to focus on this today. While some do have signs of chronic energy deficiency, I will not talk about this too much. Some have a progressive or intermittent organ dysfunction. I'll mention those briefly. And here are other disorders that have more morphological manifestations and other manifestations. If you have a patient with this kind of presentation, you think of the disorders of intermediate metabolism in your differential diagnosis, and you do these tests that I just showed. For this group of diseases, you need to consider other metabolic diseases or non-metabolic differential diagnosis, and you need special investigations, but they're also usually not so important with regard to emergency treatment. So it's important to think about disorders of intermediate metabolism in patients which have this kind of manifestation, because you really should try to get the right diagnosis very, very early to start adequate treatment. To start with the organ dysfunction group, where this is not really an acute crisis, although it can be quite rapid. When we go back to our pathway scheme, the first group that one should consider is the amino acidopathies. These are the disorders in the cytosolic breakdown of amino acids, usually before cleavage of the ammonia group. And the best example is PKU, phenylketonuria, which is really well known for a chronic organ damage. Affected children are normal at birth, and then the deficiency of the enzyme phenylalanine hydroxylase, the first enzyme in phenylalanine degradation, causes a rise of phenylalanine and metabolites, and that interferes with brain metabolism and causes progressive brain damage, neurological symptoms, microcephaly, and in the end, intellectual disability, severe intellectual disability. There's also a lack of the product, which can be recognized in reduced pigmentation of skin and hair. The disease is well treatable with a low phenylalanine diet and is also recognized in newborn screening. I'm afraid I'm not quite familiar with newborn screening in Egypt. But this, the symptom is you cannot really do something in the acute phase, but you have to recognize and have a long-term treatment. Diet treatment is very effective and allows the affected children completely normal development. So this is a typical example of the amino acidopathies. The clinical symptoms are due to specific toxicity of the accumulating metabolites. Energy metabolism is usually not affected. If you look at all the enzymes in these pathways, and you can think in these pathways, and some do not cause clinical symptoms, some cause completely other manifestations in the skin and others, but usually chronic progressive organ damage. Laboratory diagnosis involves amino acids, very simple. All the other tests are usually normal or non-specific. Another group with chronic or rapidly developing organ damage are the disorders of carbohydrate metabolism. Again, a group which you can put together. I quickly like to talk about the disorders of galactose and fructose metabolism. For galactose metabolites, for like galactose disorders, you have galactose metabolites that you test. Both galactose and fructose are activated by phosphorylation, and accumulation of these 1-phosphate metabolites is extremely toxic particularly for liver and kidneys, and may cause chronic or rapidly progressive liver and renal tubular dysfunction. The mechanism is the same, the onset is different based on when you take these sugars. Galactose is a component of milk sugar, so children with galactose related diseases develop symptoms after the start of milk feeding in the neonatal period, whereas children with fructose disorders develop symptoms only after the introduction of complementary food or cooking sugar. Basically the time when the symptoms start gives you an indication where to think. In a child with progressive liver and renal tubular dysfunction, galactosemia is the most common one, can be identified through biochemical analysis. For hereditary fructose intolerance, the main disorder of fructose metabolism, you need mutation studies because there's no good metabolic test for this. Treatment again is mostly dietary. In the acute situation, you stop the intake of the affected substance, and in the long term, you have to avoid this and sometimes do other measures. So this was a little glimpse into the groups of progressive or chronic organ dysfunction caused by disorders of intermediate metabolism. I would really like to focus now for the main part of my presentation on disorders that cause an acute metabolic crisis. The acute metabolic emergency, usually an acute or recurrent acute coma with or without focal neurological signs, is a common problem obviously in pediatric care. And I'd really like to go through a little bit about how you can diagnose the cause and then treat the disease quite effectively. And by doing these basic tests that I've talked about. And the main first step is to identify what is there. Is this a hypoglycemia? Is it a hyperammonemia? So it's blood sugar low or ammonia high? Or is it a metabolic acidosis? And then you have different acids that can be identified. So if you start with hypoglycemia, there are really two types of disease groups that you have to keep in mind. One is the disorders of glycogen release, glycogen storage diseases, or the disorders of gluconeogenesis. The others, and I'd like to first talk about this, are the disorders of fatty acid oxidation and ketogenesis, so the path from lipids to ketones. This pathway is required, as I said, when you have no food intake or increased metabolism for 8 to 12 hours. The first resource is glycogen. The next step is to shift metabolism to the release of lipids. That leads to an increase of triglycerides, or more specifically free fatty acids, which then are activated and transported into the mitochondria. And you should, in a fasting situation, have elevated ketones. If you have a sick child who is admitted with coma or whatever, and you measure high triglycerides, but the ketones are normal, meaning they are not elevated, then that's pathological. So normal ketones, normal for the fed state, means if you have a sick child who hasn't been eating for half a day or 2 days, and who has elevated free fatty acids, you can clinically diagnose or suspect a fatty acid oxidation or ketogenesis disorders. And then the next step is to do the special test, organic acids or isocarnitines. Isocarnitines are maybe easier because you can send a blood spot to the laboratory and you get the right diagnosis. One example is Andreas, who was a premature child, had normal early development, but at the age of 10 months, which is the typical age, second half of the first year of life, when night time sleeping periods are longer and the first infections come into the family. He had a chronic bronchitis and woke up in the morning with a very reduced general condition, which then subsequently deteriorated further. He had cold sweats, lost kind of contact. In the hospital, they found hypothermia, cardiac arrhythmia. The laboratory test showed the sticks test in the emergency situation showed a marked hypoglycemia. The keto sticks in the urine was negative. So don't use this as normal. It is pathological in the situation if you do not have ketones in the urine. And then the isocarnitine analysis shows a typical isocarnitine profile for MCAT deficiency. That was confirmed by genetic tests. And when you know that this child has MCAT deficiency, the medium chain acyl-CoA dehydrogenase deficiency, I do not want to go into the details of the individual diseases, just the group principles. When you have this particular disease, all you have to do is you have to avoid fasting. Then almost all children are quite well, and also Andreas had normal development, no further hypoglycemias. All you have to do is you have to tell the parents, if your child is sick, please come early to the hospital for a drip for early sugar to give a glucose infusion. So fatty acid oxidation disorders are characterized by impaired provision of energy during fasting periods, usually after lag period of say 12 to 18 hours. Often in the second half of the first year of life, leading to a neurological deterioration. A quarter of the undiagnosed children die with MCAT deficiency, but once you know it, it is easy to treat, and that's why it's also included in newborn screening in many countries. There are also other disorders of fatty acid oxidation that also have other additional problems. I don't want to go into details. Just want to highlight the importance of using these basic and special tests to really get the right diagnosis and start the appropriate therapy. Very briefly, the other cause of hypoglycemia, which is the disorders that affect the release of glucose. They usually start earlier because glycogen metabolism is started after very few hours in a fasting situation. After 3 or 4 hours, you kind of tap into your glycogen stores to get to keep your blood sugar up, and if that doesn't work, then you have a problem. EDIP was an example for this. Pregnancy and birth unremarkable, had an icterus after birth, and at the age of 3 months, so that's earlier than in a child with fatty acid oxidation disorders, he had in the middle of the night a seizure, was admitted to the pediatric hospital, comatose, hypotonic. He looked proper. I mean, stature was full, but he had a large liver and a large kidney. And the laboratory said, we have a problem because we can't measure anything because the blood has so many lipids. The capillary blood sugar showed low as a hypoglycemia. So that allows the clinical diagnosis without any other test of a glycogen storage disease type 1, a common cause of exactly this constellation. In glycogen storage disease type 1, the last step of the release of sugar, of glucose, from activated glucose, glucose 6-phosphate, which comes from glycogen or through gluconeogenesis, is inhibited. And you have basically hypoglycemia plus other changes. I go back to this picture here. You have low blood sugar, and the body really tries to produce energy. It releases massive amounts of lipids. That's why you have this extremely lipidemic blood sample. The ketones are high, unlike in fatty acid oxidation disorder. You have high triglycerides and high ketones because that isn't impaired, this pathway. And amino acids, alanine are fed and other things are fed into gluconeogenesis, which causes an increase of lactate, but it doesn't go as far as blood sugar. So when you have this combination, think of a glycogen storage disease. And the most important one to think of is van Gierke disease or glycogen storage disease type 1. You treat it by avoidance of hypoglycemias and fasting periods. You give frequent meals, slow resorbing carbohydrates at night during gastric tube, uncooked cornstarch, and there are other complications that you have to treat. But I would really think once you have the diagnosis, you can look it up. The important thing is that you can easily diagnose it within a minute. When you get the phone call, we have a child, 3-month-old child with an acute hypoglycemia, and we couldn't get any blood tests because there was too much lipids in the blood. The next acute, or the next type of acute metabolic emergency is a hyperammonemia. That's when the ammonia is elevated. There again, you have only one test that you can that you have to measure, that is ammonia in the blood. If you do not measure ammonia, you will not identify these treatable disorders, and the child may get severe brain damage or may even die. An example for one of the really important causes of urea cycle or hyperammonemia disorders is Jakob, a second child of a family. Pregnancy and birth was inconspicuous. It's the typical for metabolic diseases that the metabolic abnormalities are compensated by the mother over the womb. The first day was fine. On day 2, he had progressive lethargy, muscular hypertonia, recurrent apneas, and when the doctors measured ammonia, it was massively elevated, up to 4,000 micromole per liter, which is really beyond realistic hope that you can treat this. There are other metabolic changes. You look at the amino acid profile here, that's the other test, and orotic acid, which can be recognized in the organic acid analysis. And you can immediately make the suspected diagnosis. In this case, Jakob was beyond help, unfortunately, and died at day 5. The diagnosis in this pattern is ornithine transcarbamylase deficiency. If you look at the urea cycle, here and there, ammonia from amino acid breakdown is fed into the synthesis of urea, which is excreted in the urine, and the central enzyme which kind of links carbamyl phosphate to the urea cycle is ornithine transcarbamylase, which is relevant because it's X-linked. Jakob was hemizygous for this mutation, and if he's on his single X chromosome has this mutation, the mother and other females in the family may be heterozygous. And indeed, in this family, the mother was heterozygous, was asymptomatic, but the sister, Hannah, had recurrent vomiting with somnolence, intermittent neurological signs. When you look at her ammonia, it was mildly elevated, fluctuating, and she also had heterozygous OTC deficiency. That needs to be treated, that needs to be looked after, because she can easily die in an acute situation with brain edema. So that is something to identify. Think of urea cycle defects because you can treat them also. Not in the severity with Jakob, but certainly in the situation of Hannah. Here is a summary again of different diseases. I do not want to talk to you about the individual diseases. Once you are on the right track, once you're in the group of urea cycle disorders and you do the tests, you've done the first line intervention and you easily get the right diagnosis, possibly then with a rapid genetic analysis. And you can do various methods. You can do you can remove the ammonia by hemodiafiltration and so on, and you give substances that detoxify the ammonia by removing amino acids, and I think you talk a bit about other methods and the N-acetyl glutamate in its role in urea cycle. So the summary for this group of important acute disorders caused by the impaired detoxification of ammonia, particularly in catabolic states, but also with excessive protein intake, clinical and acute encephalopathy or fluctuating chronic neurological symptoms. The core of the laboratory diagnostics is measuring the ammonia levels that must be determined in all patients with episodic unclear neurological symptoms. And there are treatment options that you can start immediately, usually in the acute phase. So the last acute metabolic emergency, and that brings us closer to the topic of organic acidurias, is the metabolic acidosis. So you have a child with an acute metabolic presentation. There may be some blood sugar change. There may also be hyperammonia, but also you have a massive metabolic acidosis, and you need to think, could that be a disease where the development of acids is in the center of the pathogenesis? You can look at the differential diagnosis of, again, the important tests that you have done, because they are available in your hospital, hopefully, and you send away the organic acids to a lab which does it also at night and on bank holidays. And from the pattern of changes, you can get the suggestive diagnosis, which leads you to the right treatment. Again, I'd like to recommend you this little booklet. This table is from the Vademecum Metabolicum, and it also tells you what exactly you should do in which situation. So the organic acidureas are disorders in the metabolism of amino acids usually after the amino group has been removed. That is quite often in the mitochondria. These are enzymes that kind of are linked to the beta oxidation enzymes, mitochondria enzymes, but encoded by the nuclear genome, that cause a specific disease pattern and require specific treatment. So they are disorders of the mitochondrial degradation of coenzyme A activated carboxylic acids from amino acid metabolism. The accumulating metabolites interfere with various mitochondrial processes. So unlike as the amino acidopathies, here energy metabolism and mitochondrial function is impaired. And the typical presentation is metabolic acidosis plus minus other alterations, particularly during catabolic fasting periods where proteins are kind of cleaved and the amino acids are broken down. The classic organic acidureas are disorders of the metabolism of the branched chain amino acids, depicted here. Again, I do not want to talk about these individual enzymes. Each of these and most of these enzymes depicted by their genes have their own disease. The common organic acidureas are propionic aciduria, methylmalonic aciduria, and isovaleric aciduria. Clinical presentation is similar, more or less. You have a severe neonatal manifestation with a metabolic encephalopathy, intoxication type after a more or less long lag period where children are asymptomatic, feeding problems, lethargy, vomiting, dehydration, neurological symptoms, muscle tone alterations leading to coma, metabolic stroke, multi-organ failure, and progressing to death if you haven't recognized and treated it. There are also attenuated late onset forms, usually associated with hypermorphic pathogenic variants, where the presentation is variable. It includes recurrent acute episodes of metabolic derangements, usually linked to catabolic states, but can also be chronic progression of organ dysfunction. The laboratory findings are a bit more complex, and these so you may have both low and elevated blood sugar. Ammonia may be elevated. Sometimes it's difficult to distinguish organic acidureas from hyperammonemias. And it's important then to do these organic acid and acyl carnitine analysis to really come to the right suspected diagnosis. The last step is, in any case, then the genetic analysis. Again, you have treatment options. The mainstay in the acute phase is the reversal of catabolism, glucose infusion, a transient stop of protein intake. You give carnitine. Carnitine increases the detoxification by allowing the transport of these activated acyl carboxylic acids across the mitochondrial membrane. And the long-term therapy is a low-protein diet, giving amino acids that are not involved, not affected in the breakdown, other supplements, and so on. Just to mention, there are also a group of cerebral organic acidureas that do not have a typical metabolic derangement, so no hypoglycemia, hyperemia, and so on. They are usually neurological, often chronic, sometimes acute. You often have typical neuroradiological findings, and the diagnosis is done by urinary organic acid analysis it's nice to find the suspected diagnosis before you do the genetic test. Important examples are glutaric aciduria type 1 and 2-hydroxyglutaric acidureas, but there are various other diseases in that group. I only want to briefly mention the large group of mitochondriopathies that cause lactic acidosis in early childhood, where there are primary disorders of energy metabolism. This affects various organs that are strongly dependent on cellular chemical energy. The course is quite variable. It's often a rapid or episodic deterioration. Diagnosis was traditionally difficult, is now much more easy by exome sequencing and mitochondrial DNA analysis. They are not quite as important as these other disorders of intermediary nutrient metabolism because the therapy is limited. In the disorders of nutrient metabolism, it is important to recognize them, to diagnose them early, because you have treatment options. And what I want to kind of show or what to talk about with this presentation is that metabolic diseases are easy when you think not in disease, but in groups of disease. If you think in pathways, you understand the alterations and the changes that you may observe, then you can really, without much problems, without any complicated trio exome analysis, you can make the right diagnosis and you can start the right treatment. So this is all I have prepared. If it is possible, I'm happy to take some questions. And again, I'm very sorry that I am not personally in Cairo. I would have loved to come. Maybe you can come at a different time, talk about something else or the same again. And I hope you have a very nice and interesting conference. Thank you very much.
Thank you, Professor Johannes. Okay, so the questions will be at the end of the session.
I have the problem that I will have to give a lecture in half an hour. So I will not be able, I'm very sorry, I cannot participate because I have to give a 2-hour student lecture. That's the reason why I'm not in Cairo. So if there are any questions, I would need to answer them now. Otherwise, I'm afraid I cannot answer the question.
Any questions?
Thanks, Professor Johannes, for the informative presentation. I just need to ask just one question. In some it present challenges during the management of metabolic patients during acute metabolic decompensation. Some of our patients, like for example, maple syrup urine disease or organic acidemias, come with acute respiratory illness. And sometimes the ICU team informs us that I have to stop oral feeding for 1 or 2 days, or even more. What shall I do in this period? Though I have to give safe formula parenterally. My question is there available parenteral safe protein formula for those patients, for example, maple syrup urine disease or other organic acidemias during the period of fasting, or I have to depend on the routine parenteral protein formula during this period of illness?
Question: the stop of protein intake is only appropriate for the emergency situation, say 1 to 2 days, because after that you would have, if you have no protein intake, you have further catabolism, and then you make things worse. If you know that it's maple syrup urine disease, you should give the amino acids. You should start in a low protein intake to cover the needs so that you don't have a lack of protein. And you should add the amino acids that are not affected in their breakdown. So you don't, you give amino acids without the branch chain amino acids, and that should provide the relevant essential amino acids for anabolism. But you shouldn't keep going for days without protein. And the standard protein mixtures are not good enough really because they do not, they include, for example, branch chain amino acids. So then you give what's really the problem of the disease. So I would really hope that you can have an acute supply of important amino acid mixtures which allow you the specific treatment that is correct for your patient. The right diagnosis can be done when you have amino acid analysis available, and these tests that I talked about, you should have a rapid diagnosis, and then there are specialized also the provision of these amino acid mixtures should be possible by rapid mail or whatever, somewhere from the region so that you can really treat it adequately in the acute situation. Do not stop protein for days because that makes it worse, or then it starts again. And you should have a rapid diagnosis and then really have the rapid therapy that is geared towards your patient. Is this helpful?
Thank you, but I think Dr. Shaima is asking if the patient cannot be fed orally, STPN.
You should start orally.
You can
I don't think that once you have the patient stabilized, you should start oral feeding.
Okay.
It's better. Better intake is oral than IV.
If he is, have severe respiratory distress, that can be fed orally. STPN is enough.
I don't think that you need parental nutrition. But I probably may not be the best person to advise on that. But I think you should try to start oral feeds earlier than later. It should be possible. When you have a metabolic disease, you should be able to really, once you have the right diagnosis, you should even over tube feeding, you should be able to give the protein, the amino acids over an orally. Our Tofek may be better to comment on that.
Thank you very much. So yes, I mean, usually we don't recommend to have, especially for maple syrup during disease, to have the patient or the child without feeds, without amino acid formulas. Actually, the recommendation now, as you know, to give amino acid formulas right away, if possible. However, in certain situation, of course, if the oral feeding or NGT feeds is not available or not recommended, you can give TPN, but make sure that you remove the offending amino acids if this will be available in your pharmacy. Thank you very much.
Any other questions? Thank you. Thank you, Dr. Yohannes. And now we have the pleasure to introduce my dear friend and colleague for the last more than 25 years, Professor Ola Khalifa, Professor of Medical Genetics at James University, and have a great interest in metabolic disease and skeletal dysplasias.
Thank you, Professor Sulay, for this introduction. Bismillah ar-Rahman ar-Rahim. It's a great pleasure to share today on the third annual Congress of the Department of Medical Genetics, and which is a part of the 43rd annual Ain Shams University Congress. And it's a pleasure for me to share an interesting presentation on methylmalonic acidemia's clinical spectrum. My presentation flow chart will be introduction to inborn errors of metabolism, followed by classification of organic acidemias, methylmalonic acidemia's background, and then clinical spectrum and conclusion. And actually, after the full comprehensive lecture which has been given by Professor Johannes, I'll go quickly for the inborn errors of metabolism introduction. Inborn errors of metabolism are a large group of rare genetic diseases that generally result from a defect in an enzyme or transport protein, which results in a block in a metabolic pathway. And also there is a classification, group 1, group 2, group 3, as I've said, mentioned before by Professor Johannes, disorders which give rise to intoxications, disorders give rise disorders involving energy metabolism, as well as disorders involving complex molecules. Intoxication disorders that have been mentioned, also including amino acidosis, for example, maple syrup urine disease, organic acidemias, for example, methylmalonic propionic isovaleric acidemias, that are well known as the most prevalent organic acidemias, and urea cycle disorders. Organic acidemia is also known as organic aciduria, class of inborn errors of metabolism characterized by accumulation of abnormal and usually toxic organic acid metabolites and increase the excretion of organic acid in urine. They result primarily from deficiency of a specific enzyme and breakdown pathway of amino acids. Classifications have been mentioned also: branched chain organic acidemias, multiple carboxylase deficiency, as well as cerebral organic acidemias, for example, glutaric acidemia type 1. For methylmalonic acidemia, which will be focused today, methylmalonic acidemia, from its name, or methylmalonic aciduria, simply is the elevation of methylmalonic acid in blood or urine. There may be, it may occur alone, so we call it isolated methylmalonic acidemia, or in combination with other biochemical metabolites, for example, elevation of methylmalonic acid together with homocysteine, for example, combined methylmalonic acidemia and homocystinuria, and also combined methylmalonic acidemia and malonic aciduria. And I'll focus today for the combined methylmalonic acidemias and homocystinuria for the clinical spectrum, together with the isolated methylmalonic acidemias. Again, methylmalonic acidemia, elevation of methylmalonic acid may be due to due to the fact in the metabolism of methylmalonyl CoA or copolamine B12, or may be caused by dietary copolamine deficiencies. There have been shown that infant delivered to mothers, vegetarian, they do have manifestations with increased methylmalonic acid. So it's very important that we have for any newborn who has elevated C3, that we have to do B12 levels just to roll out that there is a dietary deficiency of copolamine. As have been mentioned, types of methylmalonic acidemias, isolated methylmalonic acidemia, as well as combined methylmalonic acidemia. For isolated methylmalonic acidemias, it refers to a group of inherited inborn errors of metabolism associated with elevation of methylmalonic acid in the blood and urine without hyperhomocystinemia or homocystinuria or variation in any other metabolites such as methylmalonic acid. So for those patients, so when we did biochemically, we found that there is elevation of C3, C3-C2 ratio, and then we did the urine organic acid, there will be a profuse increase in methylmalonic acid, and after doing the homocysteine level, it will be normal. So we will categorize those patients as isolated methylmalonic acidemia. It is caused, as I've said, complete or partial deficiency of the enzyme methylmalonyl-CoA mutase. Either complete deficiency, it will be mut0, or partial deficiency, it will be mut-. A defect in the transport or synthesis of its factor copolamine, copolamine A, copolamine B, copolamine D, MMA, or deficiency of methylmalonyl-CoA epimerase. Those are the causes for isolated methylmalonic acidemia. As we show in this algorithm here, we can see the proponyl-CoA. By proponyl-CoA carboxylase is converted, which it is a biotin-dependent enzyme, converted into D-methylmalonyl-CoA and then L-methylmalonyl-CoA, and then by methylmalonyl-CoA mutase, which required adenosyl copolamine as a cofactor. Also, it is converted into succinyl-CoA, which is intermediate in the citric acid cycle. So if we encounter deficiency either in methylmalonyl-CoA mutase, and as I've said, mutant 0 or minus, or deficiency of adenosyl copolamine, whether copolamine A, B, or D, variant 2, leads to increased methylmalonic acid, and in absence of increased homocysteine, as I said, it is known as isolated methylmalonic acidemia. For isolated methylmalonic acidemia phenotypes, prior to the advent of newborn screening, currently we are thankful for newborn screening that we do have a lot of cases which have been recognized early, because for all inborn errors of metabolism, time is very important. Times from the patient has been received in the ER till the start of treatment is crucial. It is crucial for the development of these patients, and also to guard against the complications which can happen to those patients. So before advent, or prior to the advent of newborn screening, there is two phenotypes: infantile, non-B12 responsive form, that would say mut0 enzymatic subtype and copolamine B. Those are the most common phenotype. Those infants present, if not treated, they can present with a catastrophic presentation, usually as known for all the important errors of metabolism and intoxication group. There is usually a lag period for a build of toxic metabolites. So those patients has been, when we encounter a newborn who had been readmitted for the hospital or to an ICU, again, he was a full newborn without any complication, we have to think about inborn errors of metabolism. And the presentation, there can be either lethargy, tachypnea, hypothermia, hypotonia. Those are not definite symptoms, but this is a suggestive. So we must have a high index of suspicion. For all important errors of metabolism, we don't have a specific signs or symptoms, but we have to have a high index of suspicion. We are said that it is most likely these are the presentations, but we have to think metabolic, as we have been mentioned, because there is treatment for those patients, and once we intervene, there will be good prognosis, and what we need all good quality of life of those patients. Also, as I've said, from the metabolic decompensation, there can be also a vomiting or dehydration, sepsis-like picture. And important in the ER, when they saw these patients, for example, they do have thrombocytopenia and also leukopenia, they thought about sepsis. So very important that we have to run septic workup parallel with important errors of metabolism. We have to send the basic investigations quickly, which will have to be, the result of it has to be given, or the result has to be due rapidly. And hand in hand, we have to send the septic workup, for example, throat swab, blood culture. If the patient has a central line, we have to do it central or peripheral urine culture. And when the result came to us, it's negative, it's well and good. But if the result for important error of metabolism, it comes positive, it's a good, and it is a crucial thing. And also those symptoms attributed on initiation of protein-containing feeds, either for those newborns, either where they are breastfed or artificial formula. Once the infant start feeding, they start to deteriorate for the most infantile type, attributed to severe enzyme deficiency. Again, as I said, for neonates typically born after an uneventful pregnancy and show a symptom-free period after birth, the accumulation of toxic metabolites usually takes several hours to days, usually 2 to 5 days, although this not usually the role. Sometimes the delivery of the baby through or the passage of the baby through the birth canal is a catastrophic stress, and we can find some patients we do have catastrophic decompensation also with the severe neonatal form, even without taking any protein intake. This is showed just the relation between infantile enzymatic subtypes and also the clinical phenotype. As we can see here, infantile non-B12 responsive mute 0 copalamin B. For mute 0 phenotype, most common, it is a most common and severe form, typically presenting in infancy, higher rate of mortality, neurological and other multi-system complications than those with mute minus and copalamin B subtype. Renal diseases may manifest in childhood in 43% to 60% of cases, median age of onset 6 to 12 years. So it is very crucial for patients who have been diagnosed to have methylmalonic acidemia based on positive biochemical findings. We have to do molecular testing to identify genotype as it's very important. For example, if there is mute 0, those patients have to be referred to nephrology and to have nephrology consultation from early. They have to have a baseline. We have to know the baseline of these patients when we need to start for renoprotective measures for these patients, because we knew that it will be a severe phenotype and those patients could have an early systemic or secondary manifestations for methylmalonic acidemias, as despite advent in the treatment and management of methylmalonic acidemia, the complications, secondary complication will happen, but it will differ according to the genotype of the patient, which will be progressive and which will happen shortly later. On the other hand, for copalamin B, most affected persons have phenotypes that resembles mute 0. Again, higher rate of mortality and neurological and other multi-system complications than with mute minus and copalamin A. Chronic renal complications, on the other hand, it will be 60% and is less frequent than with copalamin A subtypes. On the other hand, for the partially deficient or B12 responsive phenotype, that to say mute minus copalamin A, copalamin, rarely copalamin B, and copalamin D MNA type, those are known as the intermediate phenotype. They present the first months or years of life, and the presentation can be different. There can be feeding problem, failure to thrive, and we can find protein aversion. The mother can give history that her child refused to take any protein meal, or when taking a protein meal, it causes gastrointestinal upset and vomiting. So we have to be cautious about that, and we have to be alert, and we have to increase our suspicion for this type. Also for those phenotype, they can present with isolated renal tubular acidosis and chronic renal failure in copalamin B or mute type. There may be the developmental delay, catastrophic decompensation, also in undiagnosed patients. And from the recurrence of admission with acute metabolic crisis, there can be basal ganglia injury with movement disorders, especially attributed to copalamin A or minus. Again, here for a partially deficient non-B12 responsive form of mute minus, onset may occur later, as I've said, in the first few months or years of life. Symptoms often including feeding problems, failure to thrive, hypotonia, developmental delay. And again, we have to be cautious for catastrophic basal ganglia affection, because those patients are not known before, so there is multiple decompensation without anyone noticed. So very important to have high index of suspicion, and to ask for a biochemical investigation or biochemical findings, to ask for basic as well as a specific investigation when we have a clue for patients, for example, having a protein aversion or history like that. We have to pick the patient during the decompensation because usually the patients in between and among those patients could be normal. Some persons, again, have some isolated renal tubular acidosis. On the other hand, for B12 responsive form, copalamin A and B, copalamin A, those are the milder disease course, normal life expectancy, slow decline in renal function, better neurocognitive outcome than in mut-minus mut-zero copalamin B. If not compliant with diet and injectable B12 therapy, they are at risk for significant neurological and multi-organ complication. So if we do have a molecular genetic testing, and we are lucky now that molecular genetic testing is feasible to nearly more places than before. So if we do have a patient with methylmalonic acidemia, copalamin A type, we have to strictly inform the family or the mother that those patients have to be on a good compliance with vitamin B12 injection. Because we have to tell her that if they are not compliant, they can deteriorate. On the other hand, for copalamin D, only rarely is this phenotype responsive to injectable B12, may present with isolated renal tubular acidosis or chronic renal failure. For B12 responsive copalamin D, MMA, those can present with metabolic acidosis, respiratory distress, hyperammonemia, and neurological symptoms. For the methylmalonic CoA epimerase deficiency, there is a wide range of manifestations, either from complete absence of symptoms to severe metabolic acidosis. Also, in a survey for a large patient with no definite diagnosis of the genotype of methylmalonic acidemia, they did survey for the patient, and they found that there is 10 patients identified with this phenotype. They do have ataxia, dysarthria, hypotonia, mild spastic paraparesis, and seizure. And also, those patients are not B12 responsive. Again, as I've said, milder features ranging from no symptom to severe metabolic acidosis, not responsive to injectable B12, a rare cause of persistent to moderate methylmalonic acidemia. Isolated methylmalonic acidemia phenotype, we can, on the other hand, see, on the contrary, the luckily individuals or the luckily patients who have been diagnosed by newborn screening, and those patients are lucky that they are early diagnosed without any metabolic decompensation, and started promptly management. So I've said those patients are lucky that you do have decreased early mortality, less severe symptoms at diagnosis, and favorable neurodevelopmental outcome. And this is the most important, as I said, for the quality of life of those patients, and the lower incidence of movement disorders attributed that there is decreased or little decompensation for those patients because diagnosed early. But despite, again, the advent in knowing more about methylmalonic acidemia, their secondary complication may still to occur, and they do have a lot of morbidity and mortality for those patients. For an example, major complications for them renal, such as tubulointerstitial nephritis, which can lead to chronic renal failure. So those patients had from early to have a referral to nephrology, to have baseline investigations, and to completely follow them. Also, another complications which will be mentioned in the second session, they are prone to optic atrophy, and also it could happen early, even VAB changes for asymptomatic patients. Also can happen during acute metabolic decompensation, so they have again to have referral to nephrology. Other complications also, pancreatitis, endocrinological problems, short stature, and others. So there is multidisciplinary team, and a referral from early diagnosis of these patients is mandatory. On the other hand, for combined methylmalonic acidemia, I'll focus on combined methylmalonic acidemia and homocystinuria. Again, either due to for copolamine C, copolamine F, copolamine D combined type, and the copolamine D. Those are autosomal recessive form of combined methylmalonic acidemia and homocystinuria. On the other hand, the copolamine X, it is the only X-linked recessive form for the combined methylmalonic acidemia and homocystinuria. So we'll find elevated methylmalonic acid together with elevated homocysteine, despite not all the patients do have elevated homocysteine, and we can also find for those patients increased T3, and we have to monitor those patients also regularly, and they do have low methionine. For copolamine C deficiency, copolamine C it is the most common inborn error of intracellular copolamine metabolism. Patients with early onset copolamine C, they do have growth, can manifest with growth restriction, microcephaly, dilated cardiomyopathy, even it is in utero, and then they can present the main problem lethargy, hypotonia, poor oral intake, failure to thrive. This is the main problem for the neonatal form. So those patients usually they do have recurrent admission, and they do have great care with the gastrointestinal team. No metabolic crisis with ketosis, acidosis, and hyperammonemia, but if a metabolic decompensation happens for those patients, they have to be treated like the emergency management of methylmalonic acidemia. Some patients present with hemolytic uremic syndrome. Again, those patients have to be followed with the nephrology team from baseline and to pick for these changes. Although for hemolytic uremic syndrome, it can be reversible with betaine, which mainly causes for remethylation of homocysteine to methionine, which is very crucial for the neonatal form of those patients who we have to start treatment aggressively for those patients from the start by B12, folic acid, carnitine, as well as betaine. On the other hand, again, for the early onset form, they could either a neonatal presentation, poor feeding, recurrent emesis, dehydration, lethargy, failure to thrive. And the infantile form, they can present with developmental delay, encephalopathy, seizure, microcephaly, maculopathy, pigmentary retinopathy, optic atrophy. Again, we have to know from the start which multidisciplinary team or which specialty we need to refer to help to protect them from these serious complications and to have frequent follow-up. On the other hand, for childhood, they can present with chronic thrombotic microangiopathy as well as proteinuria. On the other hand, the late onset form present in adolescence and adulthood with executive dysfunction, decline of school or work performance, social withdrawal, personality changes, dementia, subacute combined degeneration of the lateral and the dorsal spinal cord attributed to low vitamin B12. On the other hand, deficiency of complementation group copolamine D combined type, copolamine F, G, and X. Patients with copolamine D and all the other types usually present with developmental regression, thrombocytopenia, megaloblastic anemia, lethargy in the first 6 months of life. These patients don't generally have acute metabolic crisis with ketosis, acidosis, and hyperammonemia. And this nice figure I want to show you here for the elevated methylmalonic acid either due to isolated methylmalonic acidemia, as I've said, or due combined methylmalonic acidemia. In conclusion, elevation of methylmalonic acid in the blood is seen in a spectrum of disorders, included isolated methylmalonic acidemia, combined methylmalonic acidemia, and methylmalonic aciduria with homocystinuria and other copolyminopathies. Initial presentation may range from infant that appear to be septic without infection to developmental delay and neurological disability. Again, this has been attributed to the type of enzyme deficiency, whether they do have severe enzyme deficiency, they do have neonatal presentation, or some residual enzyme activity, so can present late. And very important to take home message that once we have a high index of suspicion for these patients and we have the prompt recognition, proper management, better prognosis, and better outcome and the quality of life. Thank you.
Thank you, Ola, for this comprehensive talk. If you have questions, can we keep it till the end of? Can we keep it for the end of? And now I have the pleasure to introduce our guest speaker, Dr. Muhammad Alawain. His talk will be about an approach to a patient with elevated methylmalonic acidemia. He's a professor of human genetics at Faisal University and chairman of the Department of Medical Genomics, King Faisal Special Hospital and Research Center, Saudi Arabia. He has a research interest in molecular mapping of genetic diseases and delineation of inherited metabolic disorders.
Assalamu alaikum wa rahmatullah. I should say I am very delighted to be with you. Egypt is a great country. We have been taught by a lot of teachers from Egypt. They have made a lot of impression, and most likely personality also has been influenced by great teachers from Egypt. I know Professor Ola. She was with us many years ago, and she was one of the most dedicated and passionate people I worked with. She always comes to my office with brilliant ideas, push me to publish them, and she is back to her country to help and make also her fingerprints in the field of genetics and metabolism. So I also would like to thank the organizing committee, Dr. Solaf and the others for the invitation. I like the logo, the artificial intelligence remapping healthcare. I don't know if it is the logo of the symposium or the logo of the university. The artificial intelligence. I see. Excellent. So this is a very nice logo as a global approach to healthcare. At the individual level, my message to everyone, go to your basics. Basics are the most important thing for training and teaching, upon which you can make a sound judgment. If the basics are weak, the judgment will be, everywhere. So that's my message to everyone. I give it to my also trainees. Ola, remember from the clinic that I used to teach also the trainees about how to approach methylmalonic acidemia. So she picked up this title, an approach to a patient with elevated methylmalonic acid. And I made this just in the past couple of months. I've never given this lecture before. So it is a novel presentation. The objectives, I would like to give you a global understanding of B12, a great vitamin that, believe me, that you will get from this lecture probably more than the MMA itself. And think about the differential diagnosis by understanding the whole cycle itself. And believe me, we have more than 5,000, 6,000 genetic disorders so far. The number is growing every month. There is no way anybody can cover all these disorders. I tell the people in my clinic that I will retire and I will be lucky maybe to see maybe 1,000 genetic disorders or so. That means more than 4,000, 5,000 I will never encounter in my lifetime. So the idea is not to know these diseases in details. The idea is to how to understand, as the first presentation by Dr. Johannes, group of diseases. And again, understand the basics. And then if you encounter a patient, then you can go and learn quickly and become an expert. And then something about the management itself. Cell biology, one of the most fascinating about how human is created. From this cell, thousands of proteins are working together in tandem and providing the function in the best way that everybody feels humbled to see how the body is made. وَفِي أَنفُسِكُمْ أَفَلَا تُبْصِرُونَ. So I will skip these introductory slides because, you know, the first two presentations cover them. But we have among these 5,000 disorders that I told you, or 6,000 genetic disorders, 500 of them or more are pure metabolic disorder in which there is an enzyme deficiency or a transport defect. And all of you, I guess, probably understand the pathogenesis of inborn error of metabolism between a substrate and there is a block, and then there is a deficiency, and then the pathway itself is complex. If you get out from a single gene disorder to a pathway, you will understand much better. And you will learn much better. So I will skip this slide also, but there could be multiple defects within a pathway leading to similar presentation and similar also management. I will go through with you now through some 8 or 9 puzzling cases, and you will understand that you may face a consultation with these cases because you are the geneticist, you are the metabolic physician. All people from everywhere, internal medicine and other specialties, neurology and so on, they will come back to you. So the first case scenario is a 7-day-old newborn girl with positive newborn screening, high C3, you know, which is an indication of methylmalonic. And this baby has elevated MMA and homocysteine. There is no metabolic acidosis or hyperammonemia. What's your thought? We'll go through this, but I will just dump these cases in front of you and then we'll learn through the presentation about them. A 50-year-old adult gentleman comes to the clinic with a megaloblastic anemia, and then the hematologist calls you. Somebody did a urine organic acid on him, and there is elevated MMA and homocysteine level. There is no history of metabolic acidosis or hyperammonemia, and he has also variable neurological symptoms. Believe me, the pathogenesis of this 50-year-old is the same like the 9-month-old. Comes again with megaloblastic, elevated anemia, elevated MMA and homocysteine, and no history of acidosis or hyperammonemia. A third case scenario, a 29-year-old lady with megaloblastic anemia and mild proteinuria. This is a lady I follow in my clinic. No history of recurrent metabolic acidosis or hyperammonemia, and both the MMA and homocysteine are elevated. A fourth case, a 10-month-old girl with pancytopenia due to bone marrow suppression. And this is a real case I face, you know, from Bahrain with megaloblastic anemia, mild metabolic acidosis, again with elevated MMA and homocysteine. You will learn all these from the presentation. Number 5, 11-month-old boy with recurrent episodes of severe metabolic acidosis, sometimes associated with hyperammonemia, and here the MMA is high, but the homocysteine is normal. Number 6, 2-year-old with recurrent episodes of mild metabolic acidosis and mild hyperammonemia, and both the homocysteine and MMA are elevated. Case number 7, 2-week-old newborn with hemolytic anemia, thrombocytopenia, and renal failure. And I thank Dr. Ola, she made this presentation easier for you, consistent with hemolytic uremic syndrome. And this one I face also in ICU, in the neonatal intensive care. Both the MMA and homocysteine are high. And these cases, each of them has a diagnosis different from the other one. 45-year-old with type 2 diabetes, and then the endocrinologist call you. Someone did, urine organic acid and found elevated MMA level and homocysteine level. And he has also slowly progressive neuropsychiatric symptoms. Case number 9, 20-month-old boy with hypotonia, global developmental delay, feeding problems, lactic acidosis, abnormal MRI of the brain due to basal ganglia involvement, and as routine metabolic investigations were done, has also mild elevated MMA and normal homocysteine level. So now we'll start through the journey now and understand the B12. B12 was discovered more than 65 years ago. It's called cobalamin. It's a B complex. And all the B complexes are highly excretable in the kidney. That's why it is safe to give mega doses of B12. If you look in our clinic, we give huge doses of B12, but they are non-toxic. And it is also, it's very important in DNA synthesis, methylation and mitochondrial metabolism. It's also between B12, they are the cousin, of B12 is folate. So how many metabolic pathways in which B12 plays a role? That's the question. And the answer, only 2. It cannot be simpler than this. If you go to the other vitamins, they have tons of reactions they work on. But in B12, we have only 2 chemical reactions. And these are, you see in the red circles, you have the methionine synthase, the methyl B12. And in the other red circle, adenosyl B12, the methyl-CoA mutase. These are the only 2 reactions, yet we can have extremely variable presentation because of the B12 problem. We have different forms. If you go and read them anywhere, that you can get confused sometimes. There is a cyanocobalamin, methylcobalamin, hydroxycobalamin, adenosylcobalamin. And the cyano is the one that is present in food. The others are made in the body itself. And you can have synthetic, pharmaceutical forms for all of them. Except the adenosyl, the last one, is not easily made. The cyanocobalamin, as I told you, is usually present in food. Hydroxy is our favorite in the metabolic specialty. Methylcobalamin is good for the homocystinuria related cobalamin defect, and the adenosyl is the one that works for the mutase. And if you look here in this pathway, you look the problem, yes. So, okay, it's okay. So, we start with cyano. The cyano is made in the body, within the cell, in hydroxy. And then the hydroxy either goes into methylcobalamin or goes into adenosylcobalamin. And this is the structure of methylmalonic. You hear it, it's a 4-carbon hydroxy, it's a carboxy containing acid. And the brother of methylmalonic is the propionic acid. Remember the golden rule. This is a basic. Increased methylmalonic acid is a sensitive indicator of some form of vitamin B12 deficiency. Whereas elevated homocysteine level denote vitamin B12 or folate. In other words, B12 will lead to high MMA or high homocysteine. Folate deficiency will give you high homocysteine. Remember again the golden rule. Always high MMA level indicates a form of B12 deficiency or B12 related metabolic defect. So anything that disturbs B12 intake, absorption, transport, metabolism would lead to elevated MMA. And why? Let's look at the pathway. There is only, the B12 will work on the methylmalonyl-CoA pathway. So if you disturb that one, immediately the MMA will be increased. Let's understand more the B12 journey from diet to the cell. We eat the food, it's usually animal-based food. The most rich food is meat. The red meat is the highly rich food in B12. And then it goes with haptocorrin, which is transcobalamin type 1. It goes to the stomach. In the stomach, it binds to intrinsic factor and then goes to the terminal ileum, get absorbed, and then to transcobalamin number 2, goes to the cell, and what Dr. Ola was showing you is the intracellular metabolism of B12. So we have how many proteins there? Haptocorrin, intrinsic factor, transcobalamin 2. The B12 symptoms and signs are neurological, psychiatric, anemia, especially megaloblastic, and some other also systemic manifestations. Megaloblastic anemia, very well known, but if you look at the slides in the hematology, you will find hypersegmented white blood cells, as you can see in this slide. And you will find in the bone marrow also giant granulocytic bands with a horseshoe-shaped kidney and also abnormally large red blood cells. What are the causes of B12 deficiency and metabolic defect? Let's understand, because now we understand how the journey of B12, it could be as you approach anything in genetics or in medicine, it's either acquired or genetic. So we can classify them into intake, absorption, transport, intracellular, 4 categories. The intake, the nutritional, this is associated more with poor socioeconomic status, elderly, pregnancy, vegetarian lifestyle. Sometimes maternal B12 deficiency can also lead to fetal B12 deficiency. And when the baby is born, the infant will have low B12. Or the mother is breastfeeding and she is low on B12, and the baby will have also low B12. And it's usually delayed. It takes about 4 months to be diagnosed. And people use the plasma homocysteine level as a marker because it's a lot easier to measure than the MMA itself. So case number 1, we go back to the cases now, one by one. The 7-day-old infant, newborn, who had a positive but no acidosis, no hyperammonemia, the mother was deficient in B12. Okay, it's a maternal B12 deficiency. Absorption now, we go to the gastric now, we go to the stomach. Intrinsic factor now. Intrinsic factor is related to pernicious anemia, the megaloblastic that is very difficult to treat in the old days before the B12 was known. And the one that affects the adult patients is autoimmune. It's not a genetic condition. It's autoimmune antibodies against the intrinsic factor. But it will lead to high MMA and high homocysteine because the B12 will be deficient. However, there is a rare genetic condition where the intrinsic factor is defective because of a mutation. And this is the gene is the CBLIF, and it will lead to similar also presentation. So the case number 2 that I showed you, megaloblastic anemia, high MMA, high homocysteine, but no history of acidosis. It was intrinsic factor deficiency, either acquired, autoimmune, or genetic. Now let's go to the absorption. The part of the intestine that is important for absorption of B12 is the terminal ileum. So any terminal ileitis, regardless whether it is an infection, vascular, neoplasm, infiltrative, Crohn's disease, tuberculosis, or bowel surgery, can lead to reduced absorption of B12. So this is acquired now. And this is seen in adulthood. But you will never know. You can get called by someone who did homocysteine level and will call you, I found this. How can you make an interpretation? Or back again to this absorption problem, metformin, which is the most commonly used oral hypoglycemic agent for diabetes, can lead to B12 deficiency. And there is a recommendation for family medicine about this one. So the case that I showed you, the 45-year-old diabetic, he was on metformin and developed B12 deficiency, and which led to high MMA and homocysteine and presenting with neuropsychiatric. Now, there is a genetic form of reduced absorption. It's called Emerson-Grasbeck syndrome. It's due to two genes, tubulin gene and amnionylase gene. Both of them will lead to severe reduction in the absorption of B12. The tubulin itself can have about 50 or 60% will have proteinuria. So the case I showed you, number 3, with megaloblastic anemia and proteinuria, it was a tubulin defect. Transport now. So we finished from the stomach, we finished from the intestine, now we want to transport B12 in the bloodstream. The most important protein is transcobalamin number 2, and trans from transport. Remember, number 1 is haptocorrin, and no disease has been associated with haptocorrin. Even if it is mutated, it does not cause a disease. It's a benign mutation. So transcobalamin number 2 will lead to pancytopenia, megaloblastic anemia, and sometimes mild metabolic acidosis. And I have a case with this one, and this is case number 4. We had a case with pancytopenia, they thought about leukemia and all of this, and it turned out to be transcobalamin number 2. And because B12 is deficient, both homocysteine and MMA will be high. And we published, that a series of transcobalamin deficiency number 2 long time ago. Now, the most complex is the intracellular metabolism. And it can be a mutase enzyme defect or a cofactor cobalamin defect. So the mutase, I think, was covered by Dr. Ula just a while ago. And this is the most common. If you look here, the mutase, this is the most common of methylmalonic acidemia. And the cofactor, again, is also an important part of the intracellular metabolic defect. The mutase, I think you guys, understand it very well. We rely on the high C3 and also the presence of methylmalonic acid. And you remember case number 5 that I showed you? Very high MMA, normal homocysteine, recurrent episodes of metabolic acidosis, and hyperammonemia. This is the mutase defect. Cobalamin defects are quite complex, and you don't need to know the details of each of them, but they tend to have variable phenotype, and it depends on the location of the defect. But the most common is cobalamin C, as Dr. Ola was covering just a while ago. And by understanding the pathway, you can understand why each of them cause either very high MMA and homocysteine together or one of them separately. And again, this pathway showed you also that there is a bifurcation where you can have either MMA alone or combined MMA and homocystinuria together. So high MMA, these are the cobalamin A, B, and D, and both of them combined can be F, C, D, and J, and only homocystinuria you can have the D, E, and G, and the different genes that are responsible. So case number C that I showed you with relatively similar presentation, but MMA and homocysteine elevated together was a combined cobalamin defect. And this is why cobalamin C, because it is before the bifurcation, and that's why it affects both the homocysteine and the methylmalonic acid. So the 2-week-old that I showed you with hemolytic uremic syndrome, atypical hemolytic uremic syndrome, was a cobalamin C defect. Remember, not all of them, for every rule there is an exception. So Dr. Ola mentioned the epimerase, and another gene that can cause high MMA is a mitochondrial gene called SACLA2, and this is a mitochondrial depletion. It causes CNS presentation, and usually with elevated lactate. And there is a mild elevation of MMA. The brain MRI will show basal ganglia, hyperintensity, cerebral atrophy, and leukoencephalopathy. It is due to the succinyl-CoA ligase, which is part of the Krebs cycle. And I will show you why the MMA is elevated in this enzymatic defect. If you look here, it is just after the methylmalonic pathway, so it will cause a backward accumulation of methylmalonic acid. So the case number 9 that I showed you with high lactic acid and high MMA, it is due to a mitochondrial depletion syndrome. Remember that our patient, when they present with MMA, the classical MMA, the mutase, when they come very sick, the lactic acid will be high as a secondary lactic acidosis. So to understand it better, they have to be in a stable condition. You measure the lactic acid. The mitochondria, they tend to have high lactic acid all the time. And the level of MMA is variable according to the genetic defect. So the mutase, they tend to have the highest level of MMA. The cobalamin usually 10 to 100 times, millimole per mole creatinine. And this SACLA2 also much less than the mutase. These are helpful, but not diagnostic. Now, back again to the old, slide that I showed you, the intake, the absorption, the transport. Those on the left, they tend to have hematological presentation, the anemia and some neuropsychiatric. The intracellular, they tend to have the metabolic acidosis, hyperammonemia, metabolic presentation. So there is some kind of variability between the two groups. The management. For B12 deficiency, if you go to the one on the left, B12 is highly effective. And as I told you, hydroxycobalamin is the best choice for metabolic patients. Classical MMA, there is acute and chronic management, and the combined MMA and homocystinuria need to address both treatments at the same time. Always we go with these investigations, the routine. You have to measure B12, you have to measure folate level, acetylcarnitine or tandem metabolic screen, urine organic acid, measuring homocysteine and other plasma amino acid, and quantitative MMA level. These are the machines that we use, the tandem metabolic, machine, and the plasma and urine amino acid, and also there is another machine for urine organic acid. We use the Guthrie cards, and this is acetylcarnitine profile of a patient with MMA. At the top is normal, but the bottom you see very high C3. C3 carnitine is very high. That's a marker for MMA and propionic acidemia. The way to differentiate is by doing urine organic acid. This is a normal profile for urine organic acid. And here, this is methylmalonic acidemia, very high peak of methylmalonic acid with 3-hydroxypropionic acid and 3-methyl citric acid. This is the classical biochemical diagnosis of methylmalonic acidemia. As of July 2022, more than 800 patients with MMA have been reported. Remember, as I told you before, the cytoplasmic transport is usually associated with neurological symptoms, and sometimes they can have thromboembolic problems. And the acute management, we're talking about the classical MMA. Hydration is very important with high glucose, and IV therapy with sodium bicarbonate for metabolic acidosis, carnitine for organic acidemias, and for hyperammonemia we use carglumic acid. This is the best treatment for high ammonia with organic aciduria. If nothing works, you have to dialyze them for refractory metabolic acidosis and hyperammonemia. So acute management, high glucose infusion is very critical because you want to stop the pathway, the defective pathway, you want to stop it. So you give high glucose so the body can utilize glucose instead of activating this defective pathway. We give IV carnitine and IV bicarbonate, the carnitine to clear all these toxic materials that accumulate. And we give carglumic acid, carbaglu, because we want to supplement the urea cycle better because it is inhibited by the organic acid accumulation. This is a child with some form of organic acidemia. They tend to be encephalopathic, comatose, they need to be intubated, they're really sick. And they can have metabolic stroke with a predilection of the basal ganglia. And if nothing works, they get intubated, get dialyzed until they can recover. And they are at high risk of mortality because of the metabolic disease. Long-term management, the principles, nutritional therapy, where you exclude the offending amino acid. You give oral carnitine, hydroxycobalamin, oral bicarbonate, and you may need ammonia scavenger and sometimes metronidazole therapy. If you look at this again, we give special diet for these amino acids, the isoleucine, valine, methionine, and threonine, because there are propiogenic flora that can, excrete propionic acid in the gut itself. So we give metronidazole sometimes, and we give carnitine, and we give the hydroxycobalamin. You may ask a question, should I give B12 as oral or intramuscular? And I will give you from experience. For metabolic patients with partial mutase deficiency that is responsive to B12 or the cobalamin defect, we prefer intramuscular. And we use mega doses. We use 1 milligram, sometimes once a week, sometimes every day, depends on the severity of the disease. And for the Other forms, the absorption, the intake, you may use the oral form. And oral and intramuscular, they are very similar in terms of efficacy. And I will close my presentation. This is a very close friend of mine. He's from Egypt. His name is Walid. He's now in Kuwait. We studied together in the high school. And I remember a long time ago in the high school, قال بيت الشعر هذا study يا فتى the examination قد أتى. And this is very famous in Egypt, where they can have rhyming words and so I'm very thankful to all of you, and I am hopeful also you learn from this presentation some important things.
Thank you, Dr. Muhammad, for this comprehensive and also a very targeted talk. Also can keep the question after the case presentation. It's a great pleasure to introduce a very nice case presentation will be held by Dr. Nada Hamed and Dr. Muhammad Imam. Dr. Nada Hamed Dr. Nada Hamed is a lecturer of medical genetics, and Dr. Muhammad Amin is assistant lecturer of medical genetics. Please start.
Assalamu alaikum. I am Muhammad Imam, Assistant Lecturer of Medical Genetics. I would like to thank all of you and my dear colleagues and professors for giving me this chance. I will present a case scenario. A 3-year-old Egyptian girl who was presented to her local hospital at 9 months of age with respiratory distress, persistent vomiting, disturbed level of consciousness, which progressed later to coma. Regarding the history, she is the fourth in order of birth of first cousin consanguineous Egyptian parents. Her family history was negative for sudden infant deaths or metabolic disease. She is the product of full-term normal spontaneous vaginal delivery. Her birth weight was 3 kilograms. The perinatal history were all unremarkable. She had normal growth and development till time of decompensations. She was kept on breastfeeding exclusively till age of 6 months, then started weaning without complications. At age of 9 months, she presented to her local hospital with fever, persistent vomiting, and severe dehydration. She had also generalized tonic convulsions, disturbed level of consciousness, and developed coma. She was admitted to pediatric ICU for 16 days and then discharged after improvement on anticonvulsants. At age of 18 months, she was readmitted again to our pediatric hospital in Shams University with vomiting and severe metabolic acidosis. At this point, inborn error of metabolism was suspected. The workup was done, extended metabolic screening, dried blood spot by tandem mass spectroscopy, exhibited high levels of C3 carnitine. Propionic carnitine was 12.85 micromole, the normal range up to 7 micromole per liter, and high C3 to C2 ratio. Measuring of urinary organic acids in urine showed elevated methylmalonic acid and highly elevated methyl citrate. The concentration of methylmalonic acid was 146 micromole. The normal range was up to 0.4 micromole. The diagnosis of methylmalonic acidemia was suspected based on the analysis of acyl carnitine profile and measurement of non-volatile organic acids in urine. We confirmed the diagnosis by molecular analysis, which revealed homozygous missense mutation in exon 2 of the mute gene. After discharge from pediatric hospital, she was referred to our genetic clinic for follow-up and assessment. On examination, she had normal measurements. There was no facial dysmorphism, no abnormal skin pigmentations, chest, abdomen, heart, and neurological examination were all unremarkable. The patients had regression of mental, motor, and language development. We did ophthalmological examination, which showed visually alert child with normal refraction, conjunctiva, cornea, sclera, pupils, iris, lens, as well as normal fundus examination. Electrophysiological picture revealed remarkable delay in pattern positive visual effect potential with p-value, with p100 implicate time delay in the left arm. This was the right eye, the normal. The p100 was normal. In the left eye, it showed delay. The management composed of a special medical formula free from methionine, threonine, valine, and isoleucine on 1 gram per kg per day, along with natural protein restriction, vegetarian diet on 1 gram per kg per day. Also oral L-carnitine, 100 milligram per kg per day, vitamin B12 injection, 1 milligram twice weekly. The girl showed improvement regarding motor and mental milestone. By the age of 2.5 years, the girl could walk unsupported, say 3 words, and her communication became appropriate for age. She didn't develop any metabolic crisis or hospital admission since then. As Professor Ola said, methylmalonic acidemia is a heterogeneous disorder of methylmalonate and cobalamin metabolism caused by complete or partial deficiency of the enzyme methylmalonyl CoA mutase, a defect of its cofactor or deficiency of enzyme methylmalonyl CoA epimerase. Onset of manifestations of MMA ranges from neonatal period to adulthood. All phenotypes are characterized by periods of relative health, intermittent metabolic decompensation, which usually associated with intercurrent infection and stress. Major secondary complications include developmental delay, renal impairment, metabolic strokes, dystonia, pancreatitis, growth failure, and optic neuropathy. To conclude, we characterize a clinical, biochemical, and molecular of an Egyptian girl with isolated MMA. The main symptoms that prompted the patient to visit the hospital were vomiting, dehydration, respiratory distress, infection, encephalopathy, and coma. These symptoms are all non-specific and easily missed in absence of clinical awareness of the disease. The patient had optic neuropathy, which is one of the most common recognized complications of MMA. The patient is a result of consanguineous marriage, and this raises the importance of premarital counseling. The outcome regarding motor and mental language development showed improvement on treatment. This emphasizes the need for more clinical awareness of the disease and neonatal screening. Thank you.
Thank you, Dr. Mohammed, for your presentation. Now, Dr. Nada will have some comments about the complications attributed to this case.
It's a great pleasure to me to be invited to say this talk in the conference. Thanks, chairpersons, dear professors, and colleagues. This is a brief comment on the previously described case by Dr. Mohammed. As Professor Dr. Ala mentioned about the definition of methylmalonic acidemia, which is a rare, autosomal recessive, multisystemic, inborn error of protein metabolism, it's considered a type of organic aciduria with significant morbidity and mortality in infancy and childhood. There is also a significant chance of debilitating end organ damage into adulthood. Pathogenesis of isolated methylmalonic acidemia, it's previously discussed. It's mainly depends on one of two pathogenesis. Either there is mutation in the methylmalonyl CoA mutase, or there is a problem in the vitamin B12 metabolism. Presentation is also about, it depends mainly on the pathogenesis of the disease. Either it's a neonatal period presentation or infantile non-vitamin B12 responsive, may also be intermediate vitamin B12 responsive, or a benign form of methylmalonic acidemia. We will mainly concentrate on complications of methylmalonic acidemia because, as we said, it's not just about treating the acute manifestation of the disease, it's also extends to the long-term complication, even into adulthood. Complications of MMA, it's mainly the two organs that are mainly affected on the long term in management of methylmalonic acidemia are mainly the kidney and the eye. There is also significant affection of the heart presented as cardiomegaly or cardiomyopathy. There is also risk of functional immune impairment as well as osteoporosis. We will focus mainly on the visual complications of methylmalonic aciduria. The main visual complication of methylmalonic aciduria would be the optic atrophy, which is recognized late presentation of methylmalonic acidemia, especially that the surveillance or survival of the patients of MMA is now extended due to presence of special milk formula and recent of course the screening programs, the neonatal screening programs. So all these late complications are now widely recognized. It can also lead, the optic atrophy can lead to nystagmus or strabismus, and the patients can also be presented with macular disease or retinopathy. There is a study done on 2016 on about 53 methylmalonic acid patients. Only 12 of them had to be referred to ophthalmology clinic for visual evaluation. 7 of these 12 patients were found to have optic neuropathy by fundus examination. 2 of them, the optic neuropathy developed only during acute metabolic decompensation, was an acute presentation. 4 of these 7 patients, they had absent evoked potential pattern. 1 of them was showing still preserved flash response. All these 4 patients, they showed marked attenuation of the dark adapted electroretinogram with better preservation of light adapted response. So what's the pathophysiological mechanism of visual affection of methylmalonic acidemia? A lot of theories are used to explain this complication, but we should say that this is mainly a part of the neurological damage. Optic nerve is part of the neurological system, so the mechanism of affection of neurological organs or CNS is also the main suggestive pathophysiology in affection of the optic nerve. As we know, there is elevation of methylmalonic acid in cases of methylmalonic acidemia, and this mainly leads to inhibition of succinate dehydrogenase, which is a main enzyme in the Krebs cycle. This affects the aerobic oxidation of mitochondrial glucose. The second mechanism is talking about methylmalonic acid elevation and propionic and 2-methylcitric acid elevation, leading to cell apoptosis in mitochondria, in mitochondria of neuronal cells, leading to neuronal cell apoptosis. There is also another suggestive mechanism talking about vitamin deficiency, especially those patients are all the time on protein-restricted diet. Protein-restricted diet is usually accompanied by vitamin deficiency, and this is also a strong suggestive mechanism of optic affection in cases of methylmalonic acidemia. What we conclude is that there is essential periodic ophthalmological screening is very important. It's very important for follow-up of patients with methylmalonic acidemia, especially on the long term. And particularly in children with developmental delay. developmental delay denotes that there is neurological affection. Neurological affection consequently may reflect on affection of optic nerve. Thank you.
Thank you, Dr. Nada, for your informative comment. And now we can open the floor for discussion for 10 to 15 minutes.
I have a question. استغل ان انا يعني موجود. My question is to Dr. Mohammed Alawain. Thank you for the informative presentation. It really helped us to see the broad spectrum of elevated methylmalonic acid and elevated homocysteine level. It's not only about metabolic disease, as I understand, it's also about any cause affecting vitamin B12 pathway. My question is, all the causes away from methylmalonyl mutase enzyme or coplamine defect, all causes regarding the deficiency, the absorption, the transportation of vitamin B12, they will be accompanied with elevated methylmalonic acid and homocysteine level, but there will not be metabolites in the urine, right or wrong?
If you have high, B12 defect, then both reactions will be reduced, and as a result, you will have high homocysteine and high MMA. Both of them can be detected in the blood and the urine. But I should tell you, very importantly, maybe I didn't say it in the lecture, if you take the intake, the absorption, and maybe the transport, you will have low B12 in the blood. But the intracellular metabolism, whether it is the mutase or the coplamine defect, the epimerase or the ligase, all of them, they will have normal B12 level in the blood.
This is an important difference, yes.
Yes,
this is an important
this is very important.
My second question.
Can I comment on this case? Question? Because the first case I presented 20 years ago, we didn't go directly to organic acids or molecular testing. We didn't have.
This is my question. In a country with limited resources, yes.
So first we used to measure the vitamin B12 in the child and the mother, and then we did molecular testing. But I didn't mention in the presentation. And also maybe 12 or 13 years ago, we used to have some patients with diagnosed as MMA from the neurology clinic, if you remember, and they appeared that they only have vitamin B12 deficiency because they didn't measure vitamin B12. They just assumed that the organic acids and the elevated MMA is diagnostic for MMA.
This is exactly my question.
Yes, and this
in a clinic with limited resources, we don't routinely screen or ask for vitamin B12 deficiency in any patients with elevated MMA level. Should I go back to all my patients and?
No. It just if you have a global understanding now, each patient has his own disease. Yes. So if you have somebody with recurrent metabolic acidosis and hyperammonemia and high MMA, then most likely this is the mutase, the bread and butter of our specialty. But as an expert now that you are going to go through your career, believe me, they will call you from internal medicine. They will call you from neurology. And don't look at the diagnostics now. People will have access to these things in the future. They will call you, I did urine organic acid for this patient who has had neuropsychiatric symptoms and I found high MMA. What do you think, Dr. So-and-so? So without understanding the whole cycle of B12, you could consume your time, waste your resources if you don't understand and properly come to the right conclusion. And you can also order whole exome and you are dealing with an acquired condition. So it depends. Like for example, let's say a patient with a mild form of pernicious anemia comes to the clinic with neuropsychiatric symptoms. They did these, test and they found the MMA level and they call you. So you may start thinking about genetic, and it is acquired because of immune-mediated intrinsic factor deficiency. So the global understanding of any entity, it makes it easier. And they have called us. They have called us from the neurology clinic. They have called us from somebody with demyelinating disease and have high homocysteine level. And what I learned in genetics, adult onset disease sometimes can be due to late onset genetic condition. So no need to go and do this for your patient with confirmed diagnosis.
Especially if they have hyperammonemia and metabolic acidosis.
Yeah. No. That's not the message from the lecture. The message from the lecture is broaden your mind to the wide range of disorder that in which B12 is involved and will result in high MMA if somebody measures it. No need to measure, for example, pernicious anemia. No need to measure MMA, but somebody may measure it and call you.
Yes.
Yeah. Back to your optic atrophy. I think Ono was with us. We published a paper about this, and I'm not going to talk about the paper, but I'm going to send a message that sometimes a case you see will automatically take you to a publication. So a severe case of classical MMA came to the emergency room where we had to dialyze her on spot in the emergency room. And after dialysis, she lost vision in one eye. And then there was a new African-American, ophthalmologist in our hospital. She got interested. And then what we did, we take all of our cohort and examine their eyes, and we found asymptomatic optic atrophy without any symptoms. That led to, a publication. And so that's the message, that in any of these genetic conditions that you will face, it's your observation that can prompt you into expanding the phenotype spectrum or describing something new.
Thank you so much.
We have to add that we have to need for those patients that we know the complications for early referral, because most Saudi Arabia, like Egyptian, not all of them are referred unless they do have a complications or the problem happens. So we urge all physicians to kindly refer to have a baseline for those patients, especially for the two organs, as we said, for the renal as well as optic.
Any other questions?
I have a patient who was diagnosed regularly to have methylmalonic acidemia responsive B12, or B12 responsive MMA. Should we stop natural protein extraction and continue in vitamin B12 injections only and protein and regular protein, or we should continue the natural protein restriction and other medications?
So after you start the B12, tell me the drop of quantitative MMA from what level to what level?
The initial level was 0.7, not highly elevated. But the patient, I think, started vitamin B12 injection before this level.
Before, so the level normalized.
Yes.
So in this way, you can liberate the food, because we believe the MMA level is related to the chronic, for example, kidney injury, and most likely will affect the other organs as well. So if you normalize, if the MMA is normalized, and also in cobalamin A, for example, they also tend to have high response to B12. So why to restrict them? There is no need to restrict them in this case, I believe, because definitely they will not have a crisis. They will not have a problem. However, if the MMA is still high, because sometimes you cannot push it back to normal, then you should have some kind of protein restriction.
Okay. Should I follow up other parameters other than MMA, or only MMA is the only parameter who should follow up?
We don't have easy access, for example, to 3-hydroxy propionic acid, for example. But I think if the response is remarkable, from very high level to normal level, to me that is almost like a cure. Yeah. Because you push the enzyme activity from maybe 1 to 2% to more than 5 to 10%. And that should be enough to perform the function. And if you weigh down the future anticipated problem related to MMA and the protein restriction, I think the protein restriction in these cases will have more detrimental effect than liberating the food.
I have a question, Muhammad. Did you measure the MMA level while you were initially before protein restriction, while you were giving protein restriction?
As the patient will keep on protein restriction
Yes.
and all the measurements. And
So
didn't do MMA level.
So you cannot depend the MMA level while you were doing protein restriction. It may be from vitamin B12 or from the protein restriction.
And this is a pathogenic mutation, right?
Yes.
Okay.
A second question, should we stop vitamin B12 injection for all patients who diagnosed locally to have new theory, or we continue on?
So normally any patient with newly diagnosed MMA, you will do a baseline MMA level. Then you try the B12, and then you measure, and you see the response. If there is a significant drop, let's say 50% or more, then you should continue. Otherwise, you will label them as non-responsive. This is how it is done, whether it is in B12 or Kuvan challenge or whatever, in PKU and other disorders. You have to do it for every patient. You cannot rely on, even if the enzymatic assay is available, you have to do it and give a patient a chance. That's my opinion.
Thank
you. Any other questions?
One thing about, because I don't want to teach you about every specific point, but in the field of rare diseases, you are writing the medicine. If you are making an observation and you are concluding an evidence, you are writing the medicine of this disease. So the textbook of every gene is an accumulation of knowledge from people in Egypt, people in Saudi Arabia, people in Europe, and so on. I'll just give you a brief example, and I think Ola was there at that time. We had a case of MMA that stayed in the hospital for months because of chronic pancreatitis. Did you observe pancreatitis in your cases? Yes. So when we did an ultrasound of the abdomen for the pancreas, they said there was a small stone in the gallbladder, some thickening of the gallbladder, and so on. And the family came to my office and said, we need a solution. I was not the primary physician. And they were very enthusiastic to pursue something. And then when I looked at the ultrasound, we thought about this. I remember the basics from medicine, from the medical school, that biliary pancreatitis is a common cause of chronic pancreatitis in adults, alcoholism and biliary pancreatitis. So it clicked in my mind, maybe the bile acid itself or the bile itself is triggering more and more. It's the disease it's the MMA, but the biliary itself is triggering more and more of the pancreatitis in this child. So we said, let's think about cholecystectomy. Let's try get the gallbladder out because of the chronic cholecystitis. And this has never been tried in MMA. It was a big challenge, but the family was with me. So I met with a pediatric surgeon. It was very hard to convince him. Said, never been done in this disease, subjecting this case for surgery. And luckily enough, we did it. And since then, never been admitted to the hospital with chronic pancreatitis. Never. For the past, I would say 6, 7, 8 years, الله أعلم. يعني ما أدري كم لها الحين بمصر يعني من قبل كده يعني. And then her sister went into the same scenario. And we did cholecystectomy and the same thing happened. So it is your thought, it is your observation, and sometimes you come up, no matter where you are, no matter which disease, you will have some kind of observation. If you pursue it, if you write it, if you publish it, it will be your own. Yeah, thank you very much.
Before having the nutrition symposium, I just want to conclude what we said in the last previous presentation. First, please go back to the basics. Remember the basics. Increased methyl malonic acid is not always MMA. And please follow the patients for the complications. Thank you.
It is a great pleasure to have a highly comprehensive symposium by a nutrition team for the couple of 20 minutes. Dr. Ahmad Iskander will deliver his presentation now.
Okay. Thank you very much, Dr. Salah. Thank you very much, Dr. Ala, Dr. Oyan, for giving us the opportunity to be joining you in this very usually state-of-art event when it comes to the genetic and metabolic management. It's always our pleasure as a nutrition to be part and to be partner in the journey in supporting the patient from your side. Thank you for all the attendees for staying with us. My name is Ahmad Iskander. I represent the nutrition medical affairs team when it comes to the metabolic management. So, who are we? Nutrition have a slogan of Together for a Healthier Life. We work in the field of the special medical nutrition when it comes to all fields, starting with the newborn babies with normal cases, they just need a human milk replacement, or if this baby have a very special medical condition like the metabolic diseases and they need a special management. With more than 120 years working in the field of medical nutrition, more than 600 publications and more than 120 scientific discoveries recorded for nutrition, whenever it comes to immunity support, filtering the growth, metabolic, epilepsy, gut health, allergy, or even oncology and ASU when it comes to elderly. When it comes to the metabolic, for the patient with the metabolic disorder, we bring the widest range of nutritional solution, whether it is condition specific for an inborn error of metabolism, or a low protein, low profit food, or an energy modular, or an amino acid modulars to support those babies. So this is our patient in the journey, an infant, but it's an infant with a metabolic condition. That's why we usually designing our formula to look to these two parts. It's an infant, it's need an infant formula with all the state of art when it comes to the LC-BUFA, the prebiotic, all the requirement for this infant, plus to be substrate, to remove the substrate that is offended for this special condition. As we are talking about the MMA, our product will be the MMA Anamix Infant. This product is designed to manage the methylmalonic acidemia and the propionic acidemia for the infant starting 0 age up to 12 months, and also could be used as supplementary up to 3 years. The main feature will be this formula is valine-free, methionine-free, thyrionine-free, and low in isoleucine. Other than this, it have all the other essential and non-essential amino acid, all the other required fat, carb, protein, macro, and micronutrition. It's basically like a full formula, but only the valine, methionine, thyrionine, and low in isoleucine. With all the metabolic formula with the same, it cannot be used as sole source of nutrition because it needs to be in combination with a regular infant feed or a breast milk according to your management in your clinic. When it comes to the MMA Anamix formula, we usually look and we are proud to have a very unique mixture of the prebiotic. When we look to the milk formula, there is the human milk oligosaccharides, which are the prebiotic that the mother is giving the baby through the milk to support their growth, support their immunity. And we look to this baby who cannot take enough human milk due to their metabolic condition, and we wanted to support them as much as we can at the same level as much as we can. So from this, it came the concept of the prebiotic and how to mimic the structure of the human milk oligosaccharide and to mimic the effect. From this, it came the short chain galacto-oligosaccharide and long chain fructo-oligosaccharide prebiotic mixture. This mixture is 9-to-1 mixture. It's aimed to have more than 100 different oligosaccharide structure in the way and in the same complexity of the human milk oligosaccharide and to have its prebiotic effect. It has been studied to stimulate the development of the bifidogenic gut microbiota similar to the composition found in the breast milk. Also, the metabolic activity of the gut microbiota positively impacted at the human milk oligosaccharide, eliminate the growth of the pathogenic bacteria. The frequency and consistency of the defecation is also tested to be similar to the human milk oligosaccharide and the human milk breastfed, and also reduce the number of the infection episodes, especially when it comes to respiratory and intestinal infection, compared to a formula without the glucosamine. So, this have been recognized by the EFSA, by the FDA, and backed by 30 scientific publications and 55 studies. It has been also part of the recommendation from the Commission Delegate Regulation at 2016 to have galacto-oligosaccharide, fructo-oligosaccharide combination, and the 9-to-1 was the most recommended combination. That's why we was care in our formula to have the same prebiotic composition, to have it in the two sides. We are supporting this baby in their metabolic journey by removing the offended amino acids, but in the same time, we are giving them the most state-of-art when it comes to the infant formula, the amino hydrolysate formula. Our second formula for also the MMA management will be the XMTVI. X means it's removed, M methionine, thyrine, valine, and it's also low in isoleucine. This is to be used for an older age, over 1 year. And when it comes, why we have two different formulas when it comes to a different age range? Because it's more concentrated, so the baby can use like less liquid and less formula and will be easier in the weaning journey of this baby. It also contains all the essential and the non-essential amino acids, carb, fat, fibers, vitamins, mineral, and the trace element. And it's also supplemented with the longer chain fatty acid and the prebiotic fibers. That's it for the MMA side. Thank you.
Thank you, Dr. Ahmed, for those informative knowledge about the formulas. I want just to tell you that we do have a 30-minute break, and then so we can meet after. We start a quarter 1:15. تمام؟ We'll come back من اللانش بريك الطويلة جدا, and I will have to start because Dr. توفيق ابن عمران على الأونلاين. It's our honor to have It's our honor and pleasure to have Dr. Tawfiq Ibn Amran with us. His talk will be about the classical homocystinuria, current state. Dr. Ibn Amran is a senior. Dr. Amran is a senior consultant and division chief genetic and genomic medicine at Sidra Medicine and Hamad Medical Corporation. He's an associate professor at Weill Cornell Medical College, Qatar, and New York, USA. He's also a distinguished visiting scientist at Boston Children's Hospital, USA. He contributes to the body of published knowledge in clinical and metabolic genetics with over 150 published articles in peer-reviewed journal, book chapters, and abstracts. He's a reviewer of many clinical genetics journals. He's an active clinical researcher collaborating on projects with local and regional international communities. He's a leading primary investigator in many high-profile research projects and clinical trials, and he's the best professor to talk about the classical homocystinuria. تفضل دكتور توفيق.
السلام عليكم ورحمة الله وبركاته. Thank you very much, Dr. Sulafa, for the kind introduction, and thank you also for the kind invitation. It's really my great pleasure and honor to share with you our experience and our knowledge on a classical homocystinuria. So just to start with two slides about methionine homocysteine metabolism. And the first question I would like to ask our excellent audience, what is the difference between methionine, homocysteine, and cysteine? Because these three amino acids, it's very important in our understanding our treatment for classical homocystinuria. So I will start with methionine, and as you can see, its chemical structure, it's more complicated than homocysteine. That's why we cannot form it in our body, and we can obtain methionine only from diet. So methionine, it's considered as essential amino acids, as well as it contributes to the formation and synthesis of our muscles. Second amino acids important here in this pathway is homocysteine. So as you can see, homocysteine structure is less complicated than methionine, and homocysteine, it's not essential amino acid because we can form it in our bodies from methionine, and also it's not part of muscle synthesis. So again, the presence of homocysteine, it's only an intermediary metabolite, and it's important to form methyl group, which is important in the methylation of our DNA. Cysteine. So again, cysteine is not essential amino acid because homocysteine can be converted to cysteine, so we can form it in our body. However, cysteine is very important in muscle synthesis. So this is the three amino acids you need to remember when we talk about a classical homocystinuria. Details. What is the primary defect, or what is the enzyme deficiency responsible for classical homocystinuria? So the enzyme is called CBS, or cystathionine beta synthase, and this is a very important enzyme that is responsible for degradation of homocysteine to cystathionine and to cysteine. So this pathway is called transsulfuration pathway, and there is an important cofactor here, as you can see, pyridoxine or B6. It's the important cofactor for CBS enzyme. So what happens when we have a deficiency of CBS enzyme? As a result, there will be accumulation of homocysteine, as well as accumulation of methionine and deficiency of cysteine. So this is basically the biochemical profile, and this is what we have as a marker for newborn screening. So in CBS deficiency, there is high homocysteine as well as high methionine. For example, in the morning, we heard about remethylation disorder like cobalamin C defect. And in cobalamin C defect, if we are talking about newborn screening, you will have high homocysteine but low or normal methionine. So this is the main difference between hyperhomocysteinemia due to remethylation and hyperhomocysteinemia due to CBS deficiency. If you find high methionine, this is a classical homocysteinuria. If you have low or normal methionine, this is a remethylation defect. More about the classical homocysteinuria or CBS deficiency. So the clinical presentation, it's variable, and this is, as you know, depends on the level of cystathionine beta synthase enzyme and responsiveness to B6. However, the 4 systems or the 4 organs involved in a classical homocysteinuria include central nervous system. So usually patients, they presented with intellectual disability and other neurological diseases. The second organ is the eye. So patients, they can present with eye manifestations like severe myopia and its complication like retinal detachment, as well as ectopia lentis, or downward subluxation of the lenses. Musculoskeletal manifestation, patients with the classical homocysteinuria, they will present with Marfanoid habitus and other skeletal manifestation. So whenever you have a referral or you have a patient to roll out Marfan, you need to do total homocysteine level, because this is a treatable condition and you don't want really to miss a classical homocysteinuria. The 4th system involved is vascular or cardiovascular system and the increased risk of thromboembolism, and this is the main cause of morbidity and mortality in the classical homocysteinuria. There are 2 phenotypic variants, B6 responsive and B6 non-responsive. And unfortunately, the type we have here in Qatar, and I assume in the most of the countries, including Egypt, is B6 non-responsive phenotype. The classical homocysteinuria in Qatar is the most common inherited metabolic disease we see here in Qatar. It is similar to the prevalence of PKU in Egypt. I know, for example, in Egypt, you have a high incidence and prevalence of phenylketonuria. Here in Qatar, we don't have much of PKU, but the main disorder we see is a classical homocysteinuria. Our incidence is 1 in 1400, as opposed to the worldwide incidence and the prevalence of 1 in 300,000. It is primarily attributed to a single founder, Qatari mutation, which is a severe mutation called R336C. It causing severe vitamin B6 non-responsive, and as I mentioned earlier, classical homocysteinuria is included in our national metabolic newborn screening as well as in the premarital genetic screening programs. Go over the clinical manifestations, and I am going to show you some of the photos. So as you can see, this is unfortunately a 30 years old a young lady with the classical homocystinuria. She was late diagnosed. She was born before the newborn screening. So newborn screening for classical homocystinuria started in Qatar in 2006 by measuring total homocysteine. We don't rely on methionine because methionine is not a good marker for classical homocystinuria. She has 4 affected siblings. Unfortunately, as you can see, she presented with severe intellectual disability, seizure disorder, psychotic episodes, and extrapyramidal manifestations. The second organ affected, as I mentioned, is eyes. So as you can see from these patients, they have severe myopia, they have lens subluxation, they have retinal detachment, and they go blind because of the complications. So they have marfanoid habitus. So patients with the classical homocystinuria look like Marfan syndrome. So they present with tall stature, disproportionate tall stature with long extremities. And as you can see here, they have a high arm span or increased arm span compared to the height. They can have arachnodactyly, and they can present with severe osteoporosis. So this is one of the important manifestations and the important treatment target to treat the severe osteoporosis. Present with other skeletal complications like severe scoliosis, pectus carinatum. It's another important manifestation of a classical homocystinuria. And as I mentioned, the most cause of morbidity and mortality, especially in adolescents and adults, is a stroke or thromboembolic events. So uncontrolled adults with classical homocystinuria, they present with cardiac infarction, they can present with a stroke, and they can present with a deep venous thrombosis. In 2019 about natural history, clinical, biochemical, and genetics manifestation of classical homocystinuria in our Qatari cohort. So in Qatar, we have 3 cohorts of patients, those who become symptomatic and late diagnosed. So in this paper, we included 126 patients, 69 patients late diagnosis group, 13 patients diagnosed because of family history. So we call it family screening group. And the last cohort, those who diagnosed by newborn screening. And you can see here the primary cause of diagnosis for the late diagnosed group is ocular manifestation, followed by a neurological manifestation. However, the most prevalent clinical manifestation is a neurological manifestation. So usually patients with the classical homocystinuria, they present with intellectual disability, they present with hyperactivity, and this is a very progressive neurological manifestation. As I said, they can have psychiatric manifestation. Unfortunately, we have 2 patients with a classical homocystinuria who committed suicide because of severe depression and other psychiatric manifestation. Quality of life, adherence to treatment, methionine level, and total homocysteine level compared between late diagnosed group and high screening group and a newborn screening group. And as you can see, the best IQ, the best quality of life, the best adherence to medication and diet, all obtained for those who diagnosed by newborn screening, and methionine average or medium methionine level in those diagnosed by newborn screening is around 400, and total homocysteine level in those who diagnosed by newborn screening is around 60 millimole. So this is basically our targets for those who diagnosed by newborn screening. And as you can see, this is our sample of our patients cohort. And every year we have a family homocystinuria day where all patients from the 3 cohorts, they come together, they learn from each other, and having such family days has a lot of impact on compliance, a lot of impact on biochemical controls and outcomes. Consists of low protein diet, betaine, and we use high dose betaine, pyridoxine, even though our phenotype is HB6 non-responsive. So pyridoxine is one of the is not one of the main treatment we have. Also, we supplement with folate and vitamin B12. However, poor compliance is a major issue, especially compliance with diet. We have a major issue, and I assume the same situation you have in Egypt, especially with those with a late diagnosis. So there are a lot of unmet needs, and that's why we really need a novel therapy, genetic therapy, or enzyme replacement therapy for classical homocystinuria. So I will talk a little bit, and I will end my talk by discussing and sharing the update about novel therapies. So currently in the clinical trials, there is enzyme replacement therapy to replace the missing enzyme, cystathionine beta synthase, and I will talk in more details about these trials because here in Qatar we are part of this trial. Also, I will talk about gene therapy. There are other alternative enzymes to degrade methionine and homocysteine directly. There is a chaperone therapy to restore or activate abnormal CBS enzyme, and also there are other metabolic pathway modifications, either nutritional and compounds to address metabolic imbalance caused by classical homocystinuria. Of all novel therapies. So as you can see, there is enzymes to degrade methionine. There is also compounds to alterate homocysteine conversion to methionine. There is enzymes directly degrade homocysteine. However, I will be mainly talking about enzyme replacement therapy for CBS as well as gene therapy. So Travere company They have ongoing phase 2 clinical trial, and they are planning to start phase 3 clinical trial, which our center will be part of this. So they developed an regulated modified CBS enzyme called dictibatinase, and this is administered as subcutaneous injection, and it is regulated similar to the one for PKU to have a longer half-life. And it's a double-blind randomized placebo-controlled dose, and they studied about 19 patients aged between 12 and 65 years. This is the data, the updated data from this trial, and I'm going to show you just a few slides. So the decrease in regard to total homocysteine is about 55%, and more important, the decrease in methionine is about 82%. And why this is also important, the reduction in methionine, because this will give our patients more room and more natural protein in the diet. They achieve this reduction both in total homocysteine and in methionine, regardless of the change in the diet. Our gene therapy for classical homocystinuria. So this is the mouse model for a classical homocystinuria, and knockout mouse showed facial alopecia, reduced fat mass, and showed osteoporosis, and the mouse phenotype entirely reversed when you put the mice on low methionine diet. So the virus, the virus for this gene therapy is an AAV9 capsid subtype RH11, and Victor restores liver CBS level to wild type levels. It's a single dose, and it's effective in mice at least up to 77 days. It reverses bone and fat phenotypes after 1 year, and there was also reduction of homocysteine level after injection the gene therapy. As you can see in this slide, so this is the reduction in serum total homocysteine compared to wild type, placebo, and those received AAV gene therapy. So you can see remarkable reduction in total homocysteine. And this is also increase in weight compared to placebo and wild type, and there is increase also in weight in those mice received gene therapy. So in my conclusion, until we have approved enzyme replacement therapy or gene therapy, I think diet and the available medication, especially betaine, are the mainstay of treatment in a classical homocystinuria. However, these treatment necessitate early diagnosis, early initiation of a treatment, and this only can be achieved by newborn screening. So you can see here this unfortunate young lady, she was late diagnosed because she was born before the introduction of a newborn screening in Qatar. And again, this young lady who is now about 16 years of age, she is completely healthy. She has normal growth and development. She was lucky because she was diagnosed after the establishment of a newborn screening for classical homocystinuria. Thank you very much for your attention, and I am happy to take any questions, please.
Thank you, Dr. Tawfiq. Do we have any question for Dr. Shaima?
Thank you, Professor Dr. Tawfiq, for this valuable lecture about classic homocystinuria. I just need to ask you about your experience in following up ladies with classic homocystinuria, long-term outcome during pregnancy. Do they have pregnancy complications during pregnancy, like recurrent abortion, abruption placenta, or whatsoever? I'm just asking about your experience, that's all. And thank you.
Yes, thank you very much, Doctora. This is really an excellent question. So thank you for asking. So currently we have only 2 adult females. They are married and they have successful pregnancy. We didn't, so far, we didn't notice any complications. Of course, we did the premarital screening, and both of them, their husbands are not carrier. So obviously there is no risk for the baby. And as you know, homocysteine is not teratogenic, unlike phenylalanine. And we didn't notice any complication. However, in the first 3 months, whenever they are admitted for vomiting, we have just to implement emergency protocol. Other than this, we didn't notice any complications, but we have only 2 ladies. For male, we have a lot of male who are married and they have kids with the classical homocystinuria.
I have also one question about osteoporosis. Osteoporosis is, I think, related to homocysteine more than methionine, because remethylation defect also have severe osteoporosis. What do you think, Doctor?
I agree with you, Dr. Salafa. It's more, related to homocysteine and its effect on bone, as well as, in those who with the strict, just like any other metabolic disorder like PKU, we need to pay attention to other deficiencies like vitamin D, like calcium. So nutritional deficiency also contribute to the high risk of osteoporosis.
Because remethylation defects, we don't restrict the diet, and they also have osteoporosis. And this is why the genesis of osteoporosis in this disease, phenylketonuria and methylmalonic acidemia, we restrict the diet, and we think that this is one of the causes. But in remethylation defect, patients have high homocysteine and low methionine, but also with normal diet they have severe osteoporosis. Do you think we should give bisphosphonate for these patients?
Yes, till now we didn't have, especially for adults, we didn't have any patients with severe osteoporosis, or at least with the clinical fractures that necessitate the need to give bisphosphonate. But obviously, Doctora, if there is fracture or severe osteoporosis, as far as they know, there is no contraindication to give bisphosphonate.
Okay.
So yes, it's indicated.
Kindly, I want to ask about between for patients in the treatment. You encounter patients with classical homocystinuria who got attacks of seizure, because I do have one patient, once she started, and even 2 times she got a seizure attack and abnormal EEG. I read about there is one reported cases, but for a combined methylmalonic acidemia and homocystinuria on betaine. Could you kindly tell me also, do you encounter such a scenario?
So as I mentioned, Doctora, for seizure, we don't see it common, even though we have very few patients with the seizure disorders, but we don't see it common in the classical homocystinuria. Regarding and if there is seizure, it's easy to control. So it's not interactable. It's not interactable seizure.
Question, it's related just to after betaine administration, not.
Okay, and understand. So I don't think, Doctora, there is a relation, because as I mentioned, we have patients, in long time on betaine, like, more than maybe, 20 years. And as I mentioned, we give a high dose from beginning. So usually we start with 250 milligram per kg BID, and most of our adult patients, they take up to 12 grams daily, like 6 grams BID, and we didn't notice any relation like seizure to betaine.
We are dealing with high homocysteine and we cannot do anything because she does have seizure. Thank you very much. Any other questions? Thank you, Dr. Tawfiq, and I hope you can stay with us until the end of the conference. And now,
thank you very much, Doctora, and congratulations. I really enjoyed the lectures in the morning, so congratulations.
It's a great pleasure now to introduce the second session. Second talk will be a case presentation by Dr. Shayma Agad. Dr. Shayma is a lecturer of medical genetics, and also Dr. Abdullah, assistant lecturer of medical genetics. Please, Dr. Shayma.
Assalamu alaikum. It's an honor for me to be with you today presenting this case. Thanks, dear professors. Thanks, audience, dear colleagues. I present a case scenario about YA. He is an 8-month-old neonate, high risk for copolamin C defect. He is the fourth order of birth of 1.5 consanguineous marriage. His obstetric and neonatal history: he was born by cesarean section at full term, 37 plus weeks, with low birth weight and symmetrical IUGR. His birth weight is 1.3 kilograms, and he was admitted to NICU shortly after birth due to RD2, respiratory distress grade 2, and a suspected inborn error of metabolism. His family history contains he has consanguinity, 1.5 consanguineous marriage. He has 3 sepsis deaths, one at the age of 4 months, not diagnosed, and another female at 3 months, not diagnosed also. The third one died also at the age of 3 months after a period of normalcy. He has severe metabolic acidosis, severe anemia, elevated C3 to C2 ratio. Luckily, we do DNA extraction, and he was found to have pathologic or likely pathogenic variant in MMA CHC gene, which is associated with copolamin C defect. History of present illness: after delivery, the patient was distressed and was put on CPAP. CRP was elevated. He had done EMS, which showed elevated C3 to C2 ratio. So he was started on aggressive management of severe neonatal form of copalamin C defect. We gave him IM intramuscular, vitamin B12, folic acid, carnitine, while awaiting for the results of both MMA and homocysteine level. Examination now, he has fair general condition. He is conscious, active, weight 5.2 kilograms, minus 4.1 standard deviation. OFC 41.5 centimeter, minus 2.1 standard deviation. Length 60 centimeter, minus 4.3 standard deviation. He has hypotonia, no pathological reflexes. His developmental history, he has delayed motor milestones mainly. At the neonatal period, he was having, while doing routine investigation, he was having mild metabolic acidosis with compensation. BCO2 was, BH was 7.3, bicarb was 17.8, BCO2 was 30. Ammonia was normal, 1.48 microgram per milli. CBC urea electrolytes were unremarkable. CRP was elevated. Plasma homocysteine was highly elevated, 250 micromole per liter. MMA level was also elevated, 24 micromole. Echo heart was unremarkable apart from small BFO. We have done molecular study for our index case, which showed homozygous mutation at the MMA CHC gene, like his SIBS. So diagnosis of combined methylmalonic acidemia and homocysteinuria was confirmed. Our management, there is no dietary restriction in this type of copalamin defect. Hydroxycopalamin given 1 milligram IM daily, folic acid 1 milligram daily, L-carnitine per os 100 milligram per kg per day divided every 12 hours. V drop 4,000 international unit per day. As part of follow-up, we found elevated homocysteine level above 45, which makes him at risk of thromboembolic manifestations. So betaine was started at 100 milligram per kg per day divided every 12 hours. Then we escalated and done increment in the dose of betaine until we stabilize the levels of homocysteine below 45. Follow-up for this case, growth and development at the clinic, extended metabolic screen. Luckily, after control of the condition, the C3 and C3 to C2 ratio normalized after control of the condition of the baby. Also, we use EMS to monitor methionine while giving betaine therapy, as betaine therapy elevate methionine levels in the blood. We do regularly plasma homocysteine monthly, plasma methylmalonic acid monthly. We do follow-up for ophthalmology, as those patients are liable for ophthalmic complications. These are the levels of MMA and homocysteine and methionine during follow-up. As you all see, we have elevated methionine and elevated homocysteine, and elevated methylmalonic acid early in the diagnosis, but then they have been lowered thanks to our diagnosis early and management. Follow-up metabolic derangement were well controlled. The patient started catching up initially, but unfortunately, he started to develop decreased oral intake with failure to gain weight and was diagnosed as having cow milk protein allergy and GERD. He started elimination therapy with hypoallergic formula and is still under workup with the GIT team. Thank you.
Thank you, Dr. Abdullah, for your interesting case. And now Dr. Shayma will comment on the case scenario.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, I have to thank my dear professors, Dr. Sulaf and Dr. Aula, for giving me the chance to participate in this great conference. Of course, I need to stress on thanking our dear guests, Professor Dr. Muhammad Al-Awain, Dr. Johans, and Professor Dr. Tawfiq bin Amran for sharing their experience and valuable knowledge with us today. And for their time, of course. Let's start. I will go through shortly through combined homocystinuria. After all that valuable lectures, little information will be added from my side. So I will start. Starting with the biochemical introduction. As Professor Dr. Amran said, that homocysteine is an intermediary product. It is a non-proteogenic amino acid. That means that it's an amino acid that does not share in the protein, in building up protein inside our cells. While methionine is an essential amino acid, it is homocysteine is synthesized from methionine by removing the terminal methyl group. What is the fate of homocysteine? Homocysteine inside our body either will be remethylated back to methionine or goes through transferation to cysteine. And this is the cycle. The cycle in the upper slide shows the methylation pathway transforming homocysteine back to methionine. As we can see that there are vitamins necessary in this pathway, which are vitamin B12 and folic acid, and vitamin B6 regarding the cystathionine beta synthase. So we can discuss shortly what are the causes that causes increased levels of plasma homocysteine. Increased homocysteine level could be attributed to different etiology. First of all, it could be due to vitamin deficiency, folic acid deficiency, B12 deficiency, B6 deficiency. All of them can cause elevated homocysteine. So I have to evaluate our patient to exclude first vitamin deficiency in those patients, as Dr. Muhammad Al-Awain said. Also, patients with chronic kidney disease may suffer from hyperemia. Drugs like methotrexate, metformin, and fibrates, I have to pay attention that that some of them may suffer from hyperhomocysteinemia. And lastly, the genetic causes, and that is our field of interest. Homocysteine is atherogenic molecule, and it causes many cardiovascular complications. Also, it causes osteoporosis, as Professor Dr. Sulaf said. Also can be related to pregnancy complications, dementia, cardiovascular diseases, and CNS manifestation. Here we are going to stress on the genetic causes of homocystinuria. The first one that is discussed in details by Professor Dr. Tawfiq is the classic homocystinuria, when there is genetic deficiency of cystathionine beta synthase, and the other genetic causes when there is defect in vitamin B12 and folate metabolism. Methylene tetrahydrofolate deficiency may result in elevated levels of homocysteine. Here I'm talking about, there are some variants in methylene tetrahydrofolate reductase gene. These are normal variants. These are not mutations. But these variants, when present in some population, may reduce the activity of methylene tetrahydrofolate reductase, ending up in increased homocysteine levels. The most common of them is 677 C to T and 1298 A to C. As I mentioned before, these are normal variants and are not mutations. Of interest, I have to mention that methylene tetrahydrofolate deficiency, when deficient, is not associated with megaloblastic anemia, so it is associated with moderate hyperhomocystinuria without megaloblastic anemia. Disorders of cobalamin metabolism, this is the second cause of genetic causes of elevation of methylene defect, methylation defect. Of course, Dr. Muhammad told us in details about the cobalamin metabolism, but just I want to remind you again about the two important coenzymes, adenosylcobalamin and methylcobalamin. Adenosyl is important for methylmalonyl-CoA mutase, while methylcobalamin is important for methionine synthase. So whenever the congenital, the inborn error of metabolism of cobalamin result in adenosylcobalamin, this will be associated with methylmalonic acidemia, and when methylcobalamin is the affected, this will be affected with homocystinuria, and when both are affected, we will suffer from combined homocystinuria and methylmalonic acidemia. Again, this is the complicated pathway of cobalamin metabolism or utilization inside our cells, starting from GIT absorption up to the utilization inside, whether the mitochondria as adenosylcobalamin as a coenzyme for methylmalonyl-CoA mutase, or methylcobalamin in the methylation reaction of homocysteine. This is the chemical forms of cobalamin. We have 4 chemical forms. Whatever they are, the 4 are similar except for the R group attached to the cobalt atom. In case if it is the cyanide group, it will be cyanocobalamin. If it is adenosyl group, it will be adenosylcobalamin. And here is the hydroxy, so the R group will be OH or hydroxycobalamin, and if methyl is methylcobalamin. And we all know that the cyanocobalamin is the form available in the supplementary and in diet. Here, this is to sum up the biochemical defects. It has been mentioned before that in isolated MMA, whether due to methylmalonyl-CoA mutase deficiency or cobalamin A, B, or D defect, only methylmalonic acid will be elevated, whereas the homocysteine methionine will be normal. In classic homocystinuria, as Dr. Omran said, there will be high elevation in homocysteine and methionine, both of them, while the methylmalonic acid will show no abnormality, or there will be normal. And in the combined form, as in our case, methylmalonic will be elevated together with homocysteine, whereas the methionine will be low to normal. The approach, it has been mentioned in details by Professor Dr. Muhammad, but I will go through it very quickly. First of all, I have to suspect from the clinical findings, then I have to search for the biochemical findings, And lastly, the diagnosis should be confirmed by molecular genetic testing. Here are the complementation group and the corresponding genes responsible for causing combined homocystinuria. It has mentioned before, as Dr. Ola said, these are the of note to say that all of them are autosomal recessive except copolamine X, the only one who is X-linked. Just want to say that of them all, the most common is copolamine C defect. It accounts for about 80% of all disorders of copolamine, and I have to reach diagnosis, as I have mentioned before, by multi-gene panel or comprehensive genomic testing, whether whole exome or whole genome testing. Here is the clinical manifestation, also mentioned by Dr. Aula Khalifa. We have 4 forms of copolamine C defect. The perinatal form, as we can see that there is a variability in the clinical picture. The one highlighted in green were present in our patient. Our patient that Dr. Abdullah mentioned, he was suffering from intrauterine growth restriction. He was born with low birth weight and he was suffering from intrauterine growth restriction. So he was presenting since birth. There is also infantile form presenting with failure to thrive, poor feeding, hypotonia, and our patient was having hypotonia and poor feeding. Also, I have to mention the hemolytic uremic syndrome. Hemolytic uremic syndrome may be fatal if left untreated. Also, maculopathy. All of these manifestations may present in the infantile form. The childhood form may only come with global developmental delay, and the underlying cause is copolamine C. The adult form present mainly with neuropsychiatric manifestation, personality changes, and poor school performance. Here I want to stress about the challenges in the diagnosis of copolamine disorders. Copolamine disorders, what are the challenges? That it's really not an easy task to diagnose or to pick up these disorders, because most of these disorders may not be identified on newborn screening, and newborn screening, normal newborn screening, does not rule out this disorder. This is the first challenge. The second challenge, as we have seen from the previous slide, the variability in the clinical picture. So variable clinical picture and variable in the age of presentation, so physicians may be confused in diagnosis of these disorders. And lastly, timely diagnosis, because I have to diagnose those patients at the proper time, as any delay in the diagnosis could be fatal or associated with poor outcome. Lastly, the treatment for those patients. This is the protocol that we are following in our clinic. The mainstay is the copolamine, and this hydroxycopolamine improves the patient's survival and outcome and should be maintained for life. Betaine up to 250 milligram per kg. In some papers, it said that it should be given in 4 divided doses, not 2 times a day, because it has a short acting effect. Also, we add folic acid, folinic acid, L-carnitine, and those patients with combined homocystinuria and methylmalonic acidemia are kept on normal diet. Lastly, few of them may present with acute metabolic decompensation. So those who come with acute metabolic decompensation, like methylmalonic acidemia, should be managed promptly. Lastly, I just want to say that those copolamine disorders, we need to identify more patients with copolamine disorders in order to better treat our patients. So we need to know more about them. Thank you. Thank you for your.
Thank you, Dr. Shaimeh, for the very great and informative talk.
And now for our youngest consultant, Dr. Radwa Gamal, and she will present also another case, another interesting case.
Thank you, all our dear professor, for this scientific meeting. It's my honor to be with you today. I will start with case scenario. "12-year-old girl presented at the age of 4 months with recurrent attack of vomiting. She is first in order of birth of consanguineous parent. She has two siblings with similar condition. One of them died at the age of 1.5 years. Antenatal history was unremarkable. She was born full-term cesarean delivery. Birth weight 2.5 kilograms. The patient was normal till the age of 4 months. Then she had recurrent attack of unexplained vomiting. She had multiple hospital admissions with metabolic acidosis, dehydration. At the age of 19 months, she was diagnosed as a case of methylmalonic acidemia. She started treatment in the form of Depovit IM injection, L-carnitine, sodium bicarb, and vegetarian diet. Vaccination history as scheduled. Developmental history, she had normal mentality. On examination, her weight was 38 kilograms. Her height was 142.5 centimeters. Skull circumference was 53 centimeters. Systemic examination was normal. Workup done. Initially, CBC revealed leukopenia, mild microcytic anemia. Renal and hepatic profile within normal range. EBG revealed metabolic acidosis with high anion gap. Initial extended metabolic screen revealed elevation of C3 acylcarnitine, C3-C2 ratio, and decrease in the methionine. This is the initial extended metabolic screen. Organic acid in urine revealed elevated MMA and methyl citrate. MMA level was highly elevated, 142 micromole. Ammonia was normal. Lactate was mildly elevated. Pelvic abdominal ultrasound was normal. Full ophthalmological examination was normal. So initially the diagnosis was based on the biochemical test and confirmed by mutation analysis, which revealed homozygous likely pathogenic variant in MMA DHC gene, giving the diagnosis of combined methylmalonic acidemia and homocystinuria cobalamin D, which cause reduction of adenosine and methylcobalamin coenzyme, in turn reducing enzyme activity, methylmalonyl-CoA mutase, and methionine synthase, resulting in accumulation of MMA and homocysteine. Once the diagnosis was confirmed by mutation analysis, the corresponding treatment was performed. Stopping of protein restriction and addition of folic acid to the previous treatment. Now the patient on hydroxycobalamin IM injection once per week, which is effective in reducing total homocysteine and an MMA. Oral L-carnitine 100 mg per kg per day, which promoted excretion of propionyl carnitine, and folic acid 0.5 mg per day. After treatment, the biochemical profile shows expected improvement. C3 acylcarnitine returned to the normal level. MMA level, total homocysteine, and organic acid urine become normal. The patient clinical symptoms were significantly improved, showing no further acute decompensation. The parent stopped follow-up with us for 1.5 years. During this period, she got another baby, presented at the age of 6 months with recurrent attack of vomiting. She had multiple hospital admissions with metabolic acidosis. No metabolic workup or genetic test was done to her. She died without treatment. Since the parent got another baby, which is now 4-year-old, she was screened at the age of 3 days by extended metabolic screen, which revealed elevation of C3 acylcarnitine C3-C2 ratio, and she started treatment in the form of Depovit, L-carnitine, and folic acid. Vaccination history as scheduled. Developmental history, she had normal mentality. On examination, her weight 16 kilogram, her height 92 centimeters, skull circumference 48 centimeters. Systemic examination is normal, including CNS examination. Initially, extended metabolic screen revealed elevation of C3 acylcarnitine and decrease in methionine. This is the initial extended metabolic screen. CBC, renal hepatic profile, EVG, 4 ophthalmological examination were normal. Now the patient on Depovit IM injection, L-carnitine, and folic acid. After treatment, MMA level and total homocysteine become normal, and the patient show normal growth and cognitive development. To summarize, we described a family of 3 affecting siblings with combined MMA and homocystinuria. One of the siblings died without treatment. The other 2 siblings are on our close follow-up. Initially, the diagnosis was based on the biochemical test and confirmed by mutation analysis. After treatment, MMA levels show treatment, and both siblings show normal growth and cognitive development. Take-home message: patient with elevated C3 acylcarnitine should be tested for total homocysteine for possibility of combined MMA and homocystinuria. Also, organic acid in the urine and acylcarnitine profile are the most commonly used investigation to detect MMA. Knowledge of the underlying genotype is of great importance as it affects the clinical course and the treatment option. It also facilitates the prenatal diagnosis and detection of the carrier state among the family members. All siblings of a child with inherited metabolic disorder should be screened for the same disorder. Without timely and effective treatment, patients with combined MMA and homocystinuria can progress to this. Thank you.
Thank you, Dr. Radwa, for stressing about selective screening. Now, we don't have national-wide newborn screening, but in families with previous neonatal death or affected child, we usually do selective screening. I just have one question. Why did you think that this could not be isolated MMA in the first child? And you did.
We thought it is isolated MMA, and we treated the patient as isolated MMA.
What made you change this diagnosis?
Every patient with elevated C3 acylcarnitine should be tested for total homocysteine for the possibility of combined MMA and homocystinuria. Luckily, the patient did molecular diagnosis. That's why we knew the diagnosis. So that is the importance of molecular diagnosis. It affected clinical course and the treatment option.
How old was the child?
Now it is 12 years.
How old was the child?
2 years ago. Lately.
Very late. Yes.
Lately, very lately.
And this stress upon what you have said, that every child with MMA should be screened
for total homocysteine to avoid this late diagnosis.
Yes, because you did protein restriction for a long time.
Yes, and this will affect the methionine will be decreased more, will be dangerous for the patient.
Okay, thank you.
But I have to comment, I think this is not because we don't know about homocysteine, but I think it is related to cost-wise. And we know for our tertiary hospital, most of the patients not can afford to do that. For this reason, this misdesign.
Is there any question for any of the previous lectures?
Good evening, everybody. There is some confusion in the chemical metabolic pathway of the amino acids. Confusion between two amino acids, cysteine and cysteine. I saw both are confused with each other. Both amino acids, there are two different amino acids, cysteine and cysteine. Different. And I saw some terminology, homocysteinuria and other homocysteinuria. Two different amino acids, cysteine and cysteine. There is confusion of such terminology in such metabolic pathways in such a group of amino acids.
Anyone who is speaking about them should be alerted and have to make sure that he writes the amino acid properly. So we have, for example, cysteinuria, which is related to the cysteine, the one with the I without E, which is a genetic condition mainly coming with renal stones, and this is seen by nephrology. So completely different genetic defect, and I agree with you. There is homocysteine, the one we are talking about, and there is homocysteine with the I. So when you read, you have to make sure you are paying attention to the E and I, so you don't write them by mistake anywhere in your presentation, in your note. Yeah, but I agree with you. Both of them are completely different.
Yes, yes. Yeah. Thanks, sir.
I have a question for Dr. Abdullah. What is 1.5 consanguinity? I didn't understand. Okay. So I am from Saudi Arabia. I didn't understand this abbreviation. This may be an abbreviation within your group, Allahu Alam. But always we go to the standard consensus among the medicine is medicine. If I say something, I try my best to be understood by any other physician anywhere in the world. So maybe this is commonly used between all of you. Sometimes we have common abbreviations, but for the sake of formal presentation, we usually use the right abbreviation.
Thank you.
Yeah.
now, lastly but not the least, Nutricia will give an interesting symposium about the also metabolic formulas related to homocystinuria. Please, Doctor.
Thank you, Dr. Ala. Thank you, Dr. Salah. Thank you again. It's nice to be again on the stage with you. So to quickly go through the story for us in this second symposium, it will be about HCU. And we will go with the same concept. Our patient is an infant with a metabolic condition. So as we said in the prebiotic, we have the same prebiotic in our HCU formula, which is the HCU Animix Infant. It's an amino-based, methionine-free powdered formula. So it will have all the essential and non-essential amino acid, but the methionine has been removed as it's the offended amino acid for this patient. Also, it be used from the birth till 12 months and could be used supplementary up to 3 years of age. It has all the essential and non-essential amino acid, fat, carb, proteins, all the requirement except with the methionine. For our HCU formula, we'll also have the prebiotic blend we talked about in the first session. But what do we have in this formula and also in the MMA formula is the LC-BUFA blend for Nutricia as well. This is a study called the Diamond Study. It was done in 81 child from birth. It meant to measure the DHA and the AA. What will happen if we have a formula with DHA and ARA? And also, what is the main balance that will give the most benefit between the DHA and the ARA? To go to the conclusion of the Diamond Study, it measured at 4 months, 6 months, 9 months, and also it continued up to 9 years of age for those babies. So what happened if we compare the supplemented formula with the unsupplemented formula when it comes to the verbal IQ, performance IQ, the full scale IQ? The supplemented formula always have a better result comparing to unsupplemented formula. So what about the balance between the DHA and the ARA? For this study, it was tested at 3 years, 3.5, 4, and 5 years, for different balances between the DHA and the ARA. You will see they have multiple scores. The dimensional change card sort attention to make sure the baby are giving attention which picture follow the same other picture. Like this is a car, a red car, it will go to the cars box, even if it have a blue car picture. And also a color game to make sure, and the children with proper attention as well. So the outcome for this study, you will see always with the supplementation or the DHA and the ARA, the kids have a better IQ, those babies. But with the balanced 1-to-1 blend, to have the same amount of DHA and the same amount of the ARA, it gave the most maximum result. You see it in the yellow color. That's why in all our formulas, it is metabolic designed formula, but also when it comes for them to being an infant formula, we was looking to all the state of art and to give those patients the better in the infant formula and all the recommendation and make sure we are giving them what they deserve as well. So that was me.
Thank you, Dr. Ahmed. Appreciating your symposium. Okay, now we can conclude our session from the homocystinuria and an update that we showed how the importance of newborn screening has been appointed by Professor Omran for the cases which were early identified for classical homocystinuria, and he points the importance that we have to rely on homocysteine for diagnosis and not to rely on methionine. And very important, as I've said, time is very important for inborn errors of metabolism, and especially as we can see for those patients for the quality of life. Also, we have been having different presentations about combined methylmalonic acidemia and homocystinuria, and again, copalamin C, which is the most common type of these disorders we have to treat those patients aggressively from day one. And because it had been reported that although it is a neonatal severe forms, once we started aggressive treatment in the form of B12 together with folic acid and protein from the start, those patients can have a good quality of life. And I want to thank you at the last. Thank
you. So before going to lunch, we just want to honor Dr. Mohammed for taking this long trip to Egypt.
But it should be made with vitamin B.
Yes. Thank you all for continuing this long day till the end. Thank you, Iris manager, and thank you, Nutricia, for supporting this conference. Thank you.
Before ending, just I want to have some also words. I just to appreciate our sincere feelings to also the organizing group for management, and also lastly but not least, I have to appreciate for the Nutricia group which and also Ricordati group, the sponsoring company for the progress and for the success of our conference. Thank you.
And now we'll go for lunch. Yes, boy.